And thank you.
Hello, everyone. My name is Professor Julie Makani, and it is an honor to welcome you to the Sickle in Africa webinar, which will run for 3 days, starting today, 19th of June, 2024, which is World Sickle Cell Day. This is a day that we commemorate and think about the people with sickle cell disease and what are the activities that we can do to improve healthcare, conduct research, and raise awareness about sickle cell disease. We will have 4 speakers this morning. We will have Professor Leon Shilolo, Dr. Yaiza Del Pozo, and Professor Fumi Olopade, and Ms. Kironde Hall. So thank you very much. Now, without much further ado, I'd like to introduce Professor Shilolo to speak. Professor Shilolo is co-chair of the Sickle in Africa Consortium, and you'll hear about the Sickle in Africa Consortium later, but Professor Shilolo is Professor of Pediatrics and Hematology at the University of Kinshasa in Lubumbashi. He's the director of the Institute of KEFA in Monkole Hospital in Kinshasa. He has been really instrumental in making and presenting and conducting world-class research in Africa on sickle cell disease. He's president of the network of sickle cell disease research in Central Africa Republic, REDAC. He's a member of the French Academy of Medicine and Congolese Academy of Sciences, and co-chair of the Sickle in Africa. So, Professor Shilolo, if you're available to speak, welcome.
Thank you very much, Professor Julie Makani. It's a real pleasure for me to be with all the participants on this webinar. As a co-chair, it's a real honor for me to start this meeting talking about the World Sickle Cell Day. I was lucky enough to be in New York on June 19, when it was declared World Sickle Cell Day. And I would like, on this occasion, to take this opportunity to pay tribute to those who fought for this disease to be recognized as a priority by the United Nations. It was a fight led specifically by women, mothers for the most part of African origin. I would like particularly to thank Madame Antoinette Sassou Nguesso, First Lady of the Congo, and Madame Edwige Bakize, President of International Sickle Cell Disease Organization, OILD. 19 June has become a day recognized globally as World Sickle Cell Day. All continents and almost all countries have been affected in one way or another by sickle cell disease since its appearance in the world more than 10,000 years ago. Sickle cell disease has contributed to the progress of medicine, and in particular the progress of molecular biology. And sickle cell disease indirectly contribute to new curative therapies, which also concern other diseases such as cancers, immune diseases, and other anemias. Nowadays, sickle cell disease can be cured through stem cell transplantation or gene therapy. These therapies are unfortunately not yet available for the majority of sickle cell patients who live in India, in sub-Saharan Africa, and in other parts of the world. I think that in spite of that, sickle cell patients can also benefit from several advantages of science progress by establishing newborn screening and early detection, protection against infections with oral penicillin and against malaria, by using mosquito nets, and by using specific drugs. Today, the main drug that is included in the essential WHO list is hydroxyurea, which is not yet, unfortunately, available in all the African countries. Hydroxyurea reduces painful episodes and serious complications like stroke, acute chest syndrome, renal failure, and so on. Hydroxyurea allows patients to go to school and to the university. It allows patients to get married and to create a family and to have a job. It also contributes to reduce social exclusion and stigmatization. This year, we all aim to take a step forward in the management of sickle cell disease globally by following the recommendation of the Lancet Hematology Commission and the WHO Afro recommendations. Welcome to this meeting. I think rich in great teams and with very appreciated speakers. Thank you very much for your attention. Over to you, Professor Julie Makani.
Thank you very much, Professor Leon Shilolo, and thank you for your leadership in East Africa, East Central Africa, Africa, and globally. Really been able to see great achievements under your leadership. Thank you very much. We would now like to welcome Dr. Yaiza Deltozo Martin. Dr. Yaiza is deputy editor of the Lancet Hematology. She joined the Lancet Group in 2017, having worked before for the BMJ and Nature Publishing Group. She's a biotechnologist with a PhD in cancer biology and oncology from University College London. And she has been she is committed and passionate about research in science policy, gender equity, and health for all, and has supported the Lancet Hematology Commission on sickle cell disease as an editor, as well as publishing a series of papers on hematology in Africa that included an article on sickle cell disease. So thank you very much for joining us in this webinar. Dr. Yaiza, welcome.
Hello, everyone. Can you hear me?
Yes, we can hear you.
Great. Thank you. Thank you so much, Professor Makani and Professor Chilolo, for the invitation to tell everyone today a bit more about the Commission on Sickle Cell Disease that we published last year on the Lancet. I'm very happy to participate in this World Sickle Cell Disease Day webinar. I want to apologize because I'm a bit cold, so sorry if I sound a little hoarse. And I'll get started now. So at the Lancet, if we can go to the next slide, please. At the Lancet, we have, as you know, we are a medical journal, as you might know, but we have the mission that medicine must serve society and knowledge must transform society. And this should help really to improve people's life ultimately. So that's why, apart from publishing science, we do special projects like commissions or series like the one Professor Makani was mentioning before, that are science-led, international and multidisciplinary projects, and they aim to transform areas of health that have been understudied or that have been neglected in the global health agenda. And the special thing about these projects is that they are focused, even though they are science-based, they are focused on policy or achieving political action in these areas that have been neglected. So I wanted to put a couple of examples of previous Lancet commissions and how they have driven change. So one of them that I thought of highlighted was the Lancet Migration Commission. In this commission, the author are proposing, and they continue to propose, a roadmap to provide health for migrant populations, which is quite a challenge. This commission got resources from, as you can see, they are listed, several non-for-profit organizations, universities, to do their work. And they keep providing really, really great estimates and data that can inform policies in countries that had refugee crises and that have other challenges with migrating populations. So that's one example of a commission leading to policy action. And I also wanted to highlight the Lancet Commission on Diagnostics, which was published also a few years ago, showing that half of the world population does not have access to appropriate diagnostics tests for any condition. And even though this commission had less backup in terms of perhaps financial support, they still managed to achieve a World Health Assembly resolution calling for building more capacity into diagnostics. So this, again, is a great way of achieving some traction in certain areas that otherwise might not receive attention. Next slide, please. So now coming to the Lancet Hematology Commission on Sickle Cell Disease, as I was saying, we generally prioritize topics that have been neglected in global health. And as you know, sickle cell disease, even though, as Professor Chilolo was saying before, there are simple and effective treatments that can really help patients. These are still not available in much part of the world. There is great inequities that patients suffer. And this is alarming because we know that the cases that this is the most serious inherited disease, and also cases are on the rise in some countries and areas of the world. As you can see there in the map, the darker colors are the ones that have more births of sickle cell every year. And therefore, this commission wanted to propose a roadmap with some actionable recommendations. So there they identify 5 areas that should be prioritized, like epidemiology, building epidemiological data, screening and prevention, established and emerging treatments, cellular therapies, and training and education for healthcare providers. This was the 5 areas that the commissioners focus on. So if we go to the next slide, please. So you can see here that basically the commission is a long document to provide you with all the evidence available out there, but the commissioners then try to come up with 12 recommendations that provide a guide for all of the community. So governments, other organizations, non-for-profit ones or industry, on what should be, if we had limited resources, which we do, as everyone does in the world, what should we be prioritizing to improve the life of people with sickle cell? I'm not gonna tell you about each of the recommendations. You can visit the website there and read them in detail if you like, but they go from, as we were saying, from building enough data capacity, as Sickle in Africa does, or ensuring that basic treatments are available around the world, to educating patient general population or clinicians to better take care of people with sickle cell. So you can read the recommendations on the web, as I'm saying. And if we go to the next slide, please. I wanted to tell you a bit here about the global reach so far in this first year. So the commission was published roughly a year ago. We did the first launch in Mujas in Tanzania, and we were lucky to count there with some representatives from the Ministry of Health, and there were some commitments made to improve access to a screening and maybe start producing hydroxyurea, I believe, in Tanzania. And also we've done other policies event in Italy and in London, where there was like political backup for the recommendations and endorsement of this. Then you can see it's a very international project where we've also had the opportunity to to promote the commission you see it in purple in the map, in different academic events and in events such as today, that to get the awareness and the word out there of this roadmap that we think can really help to focus the ideas on where we should be going. Next slide, please. Yeah, so what's next for the Lancet Commission now that we've published the document and it's a year on? So I think the next stage is, after having the document out there, will be implementation. This is a call for everyone in the community, because we need everyone to progress on these recommendations that the authors made. So implementation will be the focus. Also, we hope that now this will allow the authors to establish collaborations with other stakeholders in the field, like the World Coalition, funders, governments, WHO, etc. And we can start talking on what needs to be prioritized and why. Also, hopefully, this commission will put sickle cell disease on the map of global health agenda and secure more funds for sickle cell research or implementation. Everything is needed. And in terms of the commission, hopefully we will be building, the authors might secure resources to build a website, and from there start working more on this side of things, of the collaborations and tracking the progress. And then finally, one of the key aspects that we hope we are going to, perhaps it's a little early because it's only been 1 year since publication, but in the longer term, in the next years, we hope that the authors will be able to follow up on those recommendations and keep us informed on how we are doing as a global community in terms of achieving those. So the authors propose different measures and timings to achieve the recommendations. So hopefully they can track the progress and then give us a sense of whether we are progressing and where more action is needed if some objectives are not being advanced. So with this, I finish. If we go to the next slide, please. As Julie said in the introduction, I was simply the editor helping the authors put this project together, and I had the honor to be telling you about it today here, but really all the work was done by the authors of the commission that are named here, and also other collaborators that have helped us, as Professor Makani and others, to spread the word about this document. So we are really thankful for the support, and we hope that this can really bring about some change together with all of the other projects that are there in the sickle cell disease community. And with this, I finish. If anyone has some queries for me, my email is there. And thank you very much for your attention.
Thank you very much, Dr. Yaiza. That was a terrific talk highlighting the Lancet Sickle Cell Commission and what it found and what is being recommended. And we're really looking forward to working with the Commission and with other stakeholders in sickle cell disease to implement the recommended action points. Thank you very much, Dr. Yaiza. So we are going to have a talk now by changing the order a little bit. So I will invite Ms. Eseza Kironde-Ho, who is a patient advocate for sickle cell disease. She will introduce herself, speak about the lived experience of sickle cell disease and what is important from the perspective of the patient community. And we'll also introduce JP, who's another patient advocate. And then after their talk, we will then listen to Professor Olopade. Thank you. Welcome, Mr. Cesar. Hello, Miss Cesar? Are you able to speak? Welcome.
Hi, can you hear me now? I had issues unmuting.
Brilliant. We can hear you. That's really good. Welcome, Miss Cesar. Do you want to switch
Thank
your,
you
are you
very
able to
much.
switch your video camera on?
Yes, I can do that.
Fantastic. Thank you.
As the host, I think the host needs to let me switch on my video.
They will do it right now.
Okay, and do you have my slides?
Yes, the DCC will project the slides. Thank you.
Thank you very much. Okay, so just waiting for my... Okay, thank you. Thank you, Wilson. Good afternoon, everyone. My name is Esiza Kirande Hall. I am a sickle cell warrior and sickle cell advocate, and I'm representing Sickle Cell South Africa today. So my topic is voices from sickle cell warriors in sub-Saharan Africa, and I'll speak a bit about my experience. So I was born in Uganda in 1988, where I lived for the first 11 years, and I was diagnosed at 18 months when my first crisis happened. I've been told that's a bit late, and with how severe my sickle cell became, I'm surprised that I was diagnosed so late. But sickle cell is quite prevalent in Uganda, and it's quite prevalent in my paternal family. We had lots of cases of sickle cell there. But I never met most of my relatives with it, as they passed away quite young or before I was born. So my parents managed sickle cell as well as they could. They were quite educated with it and they had experience with it. My father had grown up with lots of cousins with sickle cell, so he had some idea on how to manage it, and my mother was quite open-minded about it. We faced very little stigma within my family, though there were comments here and there that happened. But because of how open-minded my parents are and how anti-stigma, they would not let the stigma get to me. I've also been quite open in facing my sickle cell anemia and my sickles and how it's affected me throughout my life. In the 90s, we had very few resources and very few patients were willing to talk about their experiences, which was quite difficult for me, and I know quite difficult for other warriors I have met. So from that, it was quite lonely. I grew up basically alone with sickle cell, though surrounded by sickle cell. And then we left Uganda in 1999, and we moved to Eswatini in 1999-2000, and it became even more lonely. No one had heard of sickle cell. I had to get a Ugandan doctor who could sort of treat sickle cell, but being hospitalized became quite a nuisance because they would not really listen. I looked healthy, so I was in a lot of pain. Why did I need the medication they gave me? The teachers were not as willing to be accommodative of the sickle cell. So that's when I kind of faced a little bit of stigma, but it came with them not knowing about sickle cell. Then we moved on to Lesotho and soon after Botswana, and there this was my adolescence time when I was a teenager then, and I fell very sick. My sickle cell became worse. I was sick just about every 3 months, and I'll be hospitalized for weeks at a time. There's one time I spent about 3 months in hospital. And this came with puberty, my changing body, the hormones, starting my menstrual cycle. That was quite difficult to manage. My doctor managing me, he knew about sickle cell because he was Ghanaian. So he knew about it, but he was not great at treating it. And I think another thing that he did not do well was listen to me and listen to what I had to say about my body. which I feel a lot of doctors and nurses are not willing when treating patients with sickle cell, especially younger patients. They're not willing to listen to them. They listen to the caregiver and the parents, but those are not the people suffering from the illness. And because a lot of my symptoms and my triggers were overlooked, I kept falling sick a lot until I could manage it on my own. And I was older and I had all the information and the resources, and I had the power to choose my own doctors. So then that was what was quite hard. And then knowing that a lot of the children were now starting to pass away from the sickle cell, that was knowing that I was one of the 80% of the children, I was one of the 20% of the people with sickle cell that had managed to survive. It upheaves you. It's mentally, it was quite hard for me. It was the survivor guilt that came with that. So now I'm a teenager and I have the survivor guilt. I'm now getting all the different complications, the vascular necrosis. I've got an acute chest syndrome. I have some organ failure. I don't have the proper medical care in Lesotho. And in Botswana, I now had to go to get medical care in Botswana, in South Africa. And now I'm away from my family, but I'm a 15, 16-year-old teenager. And there the doctors as well were not listening to me. This was in public hospitals, which was also quite difficult. It was difficult to navigate, difficult for people to hear my voice. I had to get a well-meaning, loving nurse to look after me and listen to me and help me out of this. As I transitioned to adulthood, we now had more access to the internet. I gained a sickle cell community, and I could now find my own doctors and find someone who'd listen to me, someone who's going to treat me well, find a hospital where I could get proper care, get nurses who looked after me. I think the most important of all has been getting nurses that will listen to me and help look after me to help me treat my sickle cell disease. And with being on, I was put then on Hydrea as well, and that has helped me manage the sickle cell really well. That and having these new doctors in Johannesburg who I've been with them for about 10 years now. They've listened to me very, very well. They ask me first how I am feeling, how it's affecting my mental health, how it's affecting my marriage, how it's affecting my children. They find my triggers. They find, they connect to me as a person, not as a patient with sickle cell. And this is something that I did not find in public healthcare, but rather in private healthcare. And I've been very fortunate to be able to afford private medical care for me to have great healthcare. And for the last 10 years now, I think I've only had 2 major crises where I went from having 6 to 8 crises a year, and just being in constant pain. So I think, yeah, finding the right medical care in Southern Africa has worked for me. It was better than when I lived in Uganda with sickle cell that was prevalent. Even though in South Africa, it is looked at as a rare disease, I have gotten incredible care here. And I have managed to have my twins. I've managed to be healthy, keep my hobbies, and live almost as a quote unquote healthy person. So yeah, that's been my experience as a sickle cell warrior in South Africa. I think I'd like to pass on to Jean-Pierre now. Right, Julie?
Thank you very much, Mrs. Cesar. I mean, your sharing your journey, your perspective, your experience is absolutely fascinating. And it's really refreshing hearing what, about your rich life, and really an inspiration to all of us who are in working in sickle cell disease and supporting people living with sickle cell disease. Thank you very much for sharing that, Eseza. Really would like to welcome Jean-Pierre. JP, please welcome to speak. And then after JP, I'm pleased to note that Professor Funmi Olopade has joined the webinar and will speak after JP. Welcome, JP. Mr. Cesar, is JP joining with you on your line, or is he
He is supposed to be getting his own line.
Okay, can we unmute him so that he can speak? Unmute the microphone.
Oh, I think, sorry, he hasn't gotten a link yet. Sorry, let me tune off and give him mine, I suppose. Would that work?
Yeah, so what we will do is we will, whilst we're sorting out the logistics for JP to speak, I'd like to invite Professor Funmi Olopade to speak. Professor Funmi Olopade is really an honor to have her on this webinar on World Sickle Cell Day. Professor Funmi is co-chair of the Sickle in Africa Consortium. She is Walter L. Palmer Distinguished Service Professor of Medicine, Professor of Human Genetics, and Director for the Center for Clinical Cancer Genetics and Global Health at the University of Chicago. She's also chair of the sickle cell, not sickle cell, the scientific advisory board that was recently formed in Nigeria. And we really have had an honor of working with Funmi from establishing genomic research in Africa through H3 Africa, her amazing work with aortic and cancer, as well as providing leadership and advice when it comes to sickle cell disease and learning from it. So very, very warm welcome to Professor Funmi Olopade. Funmi, it's an honor and a pleasure to welcome you.
Wonderful. It's very early in the morning in America, but we're home. We're celebrating Juneteenth Day and also World Sickle Cell Day. So it's really a day for us to reflect and to think about the future. I came to America to study genetics and to study sickle cell disease. And for some reason, I was told if I did that, I wasn't going to have a career. So I started on studying cancer as a way to gain access to genetics. So having this honor today is really trying to convince all of us that unless we work in solidarity, we will not be able to tell stories as the story of this beautiful sickle cell warrior who is living, thriving, and surviving. And because she's living, thriving, and surviving, I want to use my example of a disease that also was top of my mind as we excluded and we suffered lack of resources to take care of young women with breast cancer. Next slide. So to me, the President Biden really followed on what our former President Obama, who's a Kenyan and has African blood in him, beautiful man, my neighbor. When he was first elected senator and when he became president, he gave Mary Claire King a Medal of Science. And I just want to celebrate the solidarity that was in this picture, because Mary Claire King discovered BRCA1 and reached out to help me, a young investigator, study my patient. So I want to talk about this 34-year-old Black woman. And you may not see this, but this is 1, 2, 3, 4, 5 generations of this woman who had had breast cancer or ovarian cancer. And in America, we talk about young Black women dying prematurely of triple-negative breast cancer. So when I couldn't study sickle cell disease, I was really fascinated by the genetics of triple-negative breast cancer. This woman had access to the best care in the world. She got lumpectomy, radiation. She participated in research. She got her family to give us blood to participate in research. And then we identified the BRCA1 mutation in her, which meant she was born with this mutation. And if only we had discovered her before she had breast cancer, or if only I would have been able to give her the right drug at the right time, I may have prevented a lot of side effects in her. But she developed a heart problem after taking the medication I gave her. And then in America, if you lose your insurance and you cannot come to a private institution like mine, then you cannot get care. And this woman died of ovarian cancer because even at the time when she wanted to have her ovaries removed, there was no one who would remove her ovaries because the risk of doing that was just too high. And then she developed ovarian cancer. So that's why I'm using the example of sickle cell disease and the example of cancer as something that the WHO can work on. And Mary Claire King and I have talked to the WHO Science Summit, and we talk about the fact that I published this paper in 1997. Myriad Genetics used my samples to make the drug, to make the test available in 1998. Of course, do you think that test is available to everyone in the world? Of course not, even though our patients participated in the research. Next slide. And that's really because whenever people talk about why Black patients are dying, it's very easy for us to stigmatize them and say, oh, they don't participate in research. So I want to share the story of this beautiful family from Northwest Indiana. They crossed the bridge to Chicago. This woman had metastatic HER2 positive breast cancer. And 10 months after she had given birth, and she crossed over, she got access to HER2 positive breast cancer. Even though her cancer was stage 4, she's alive and well. And that child that she was able to bring into the world and her entire family, they are thriving because she gained access to life-saving medication. And this family will raise money in Northwest Indiana. They would give me, participate in research because this daughter of this woman had died of triple-negative breast cancer. Since they started raising money for research, another member of the family died from breast cancer. And this woman is alive with not only 2 breast cancers, another breast cancer and ovarian cancer, and she keeps pushing on because this matriarch of the family is determined to make sure that we can end cancer as we know it, that even though she had suffered all these losses, she was going to continue to support research. Because this is genetics, this woman and this woman are not related. She's just married to her cousin. And so you can see why we all need to know about our family history. We all need to support each other, and we need to do this work in solidarity. So she was supporting her husband, heard that, in fact, when you have breast cancer, go and talk to Dr. Olopade. And that's why this woman is alive today, because of research. Next slide. So why is this important to us on June 10th? Next slide. As we celebrate slavery and the fact that Blacks in the diaspora have not had access to what they need. So next slide. Okay, so the reason why I wanted to talk about how important this was. So this generation of people who taught me, generally, is a hematology oncologist, and they described chromosomes in leukemia. They work collaboratively together, and now WHO actually will not let anyone get treated for leukemia without using the molecular diagnosis, without looking at the genes that are altered and then matching what this patient will get. So here's genetics that was about sickle cell disease, was about breast cancer, now being about hematology. And this is why we need doctors. So this is Dennis Slayman, who also trained at the University of Chicago, and because of genetics, was able to develop Herceptin, a life-saving breast cancer medication. And then we have multiple individuals, and you can now see how diverse the face of the trainees now are. This is Dr. Abiola Ibrahim, who is a Nigerian, who is now the vice chair for Aortic African Organization for Research and Training in Cancer, and who is saying, I've gone to the University of Chicago. This is Afaf from Sudan. And they're all saying, we know that just like people in Indiana, we also want to have access to life-saving treatments and diagnosis. And we can do this in solidarity. Next slide. And I want to use the example of over the years, how many students, this was Wenji, who came to me from China wanting to go back and start a lab in China so that she can bring the best science to her population. I'm saying this because you are all going to be able to advocate for science and technology to transform how we take care of patients in Africa. Next slide. This is my trainees are from Brazil. And then everybody talks about young people, and everybody talks about people now having to think about, I'm sorry, this slide is turned upside down, but this is my team in Nigeria now doing the same HER2 targeted therapy, doing clinical trials in their own country. This was when we launched the study, and we can do proof of principle when we stay in our own country and we help each other. So the Cameroon team, the Ugandan team, and now we have people who want to do this work, and we must do it in solidarity. Next slide. So it's no longer brain drain, it's brain circulation. And wherever I go in the world, whether it's this picture was taken in Vietnam, we have women all over the world, and we talk about era of hope. We talk about the era of precision medicine. So let me end by just thanking all of you who are on the webinar. Wherever you are and you're listening to this, we can imagine it. And if we imagine it, we will be able to work together to end cancer as we know it, and then to develop the same genomic assay that we can use to identify high-risk cancer patients. Is the same genomic assay that we can use to risk stratify leukemia, is what we can use to actually identify every child with sickle cell disease so that they have a chance to survive and thrive. Thank you.
Thank you very, very much, Fumi. This is Professor Olopade. This is really, really inspirational. And one of the things that we've always, and thank you for your leadership and advice and mentorship, is really how much we can learn from each other, how much we can learn from other conditions, and to see the similarities, the areas of convergence, so that we can learn what works, what doesn't work, and really leverage what is there. So thank you very, very much for sharing that. Lots of comments and claps saying that this is very inspirational. Thank you very much, Olopade, Professor Olopade. I'd like now to finally end with JP. Have you been able to join?
While he's joining, I just want to thank Julie and all the investigators in Sickle Cell Consortium, my co-chair, Dr. Shilolo in Congo. And I know that you have brains in Africa, and these brains are there. They're pushing the needle. And what we can do is to just do it in solidarity with you all. So thank you. And, you know, I woke up at 4 a.m. to be able to do this. And really just the most important thing that we can all do, and we can do it in solidarity. So thank you.
Thank you. Thank you very, very much, Fumi. Thank you very, very much.
And happy Juneteenth to everybody. Happy.
Thank you. Happy Juneteenth, as well as thank you for commemorating World Sickle Cell Day with us on the same day. So really would like to thank our speakers. We've heard from Professor Leon Shilolo from DRC in Congo. We've heard from Dr. Yaiza Del Pozo Martin from the Lancet Hematology. We then heard from Mr. Cesar Kironde Hall from Sickle Cell Society in South Africa. We're really sorry that we were not able to hear from JP. And then finally, really having the inspirational talk, emphasizing the importance of solidarity from Professor Fumi Olopade. So really would like to thank the speakers and for their inspiring talks and sharing the perspective. There's a lot of learning there. And with that, we will finish the session, and we will be starting the next session shortly. Thank you very much, everyone, for joining this session. Please stay online, and we will start the next session at the scheduled time. Thank you very much, everyone. And what we'll do is we'll do a warm clap for all the speakers. Thank you very much.
Julie, I think we've got a bit of time for a panel discussion, if that's okay. Thank you.
Thank you, Vicky. Dr. Yaiza, Professor Shilolo, Professor Olopade, Mr. Cesar, are you able to switch your cameras on? And perhaps we can, having heard everyone, perhaps we can just spend another 10 minutes just hearing any perspectives, or if there are any questions, we can type them into the chat. I don't know if participants can speak. Thank you, Professor Segun Fatumo, for posting the question in the chat. So maybe I'll just read the comment from Professor Segun, and then I'll invite you all to speak or say a few words. So the question or comment from Professor Segun Fatumo is, thank you so much, Ms. Cesar Kironde Hall, for telling your story, which is very inspirational. I see you lead the Sickle Cell South Africa in South Africa. I wanted to ask if there is awareness of sickle cell treatment and cure, and how do you think we could work in solidarity, as suggested by Professor Olopade, to get access to these cures to those who mostly need them? So it's a general question, and Ms. Cesar, welcome to comment from your perspective. And then we can hear from Dr. Yaiza, Professor Leon, and Professor Olopade. Welcome, Mr. Cesar, and thank you for the question.
Thank you so much for the question. I think with the cure at the moment, especially with the new genetic engineering cure, the CRISPR, I think our main issue in the sickle cell community at the moment is cost and accessibility. For many of us in the Sickle Cell Society, we do not work. We rely on our family members to look after us, to fund our medical care. And for me, as a warrior who is firmly middle class, this cure for me is totally and completely unattainable. I think right now what we have to do is work with the pharmaceutical companies, with researchers, with doctors to find a way of lowering the costs. And I think if that is done, it will be more affordable for the hospitals and more attainable for most of the sickle cell warriors to get this cure. But for now, if most of us can barely afford the just hydroxyurea, painkillers, folic acid, even just vegetables to have a balanced diet, getting a cure is quite unattainable. So that would be my opinion.
Thank you very much, Mrs. Eza, for sharing that. It is certainly healthcare costs for a chronic disease is really something that needs to be done. I think a key message from Professor Lopade, from Dr. Yaiza and Professor Leon is really the importance of solidarity, working together as patient community advocates to really advocate with our leadership, with our countries at global level to raise awareness and to improve access. If there are lots of lessons we could learn from pandemics such as COVID-19, from epidemics such as HIV, and other conditions with regards to how to make interventions, diagnosis, as well as treatment accessible. So thank you very much for that. Welcome, Dr. Yaiza. Do you want to comment on the question, but also just generally if there was something that you wanted to reflect on?
Yes, well, thank you very much. I think you just said what I could add, Julie. As you know, I'm not a physician, but I do think that projects such as the Lancet Hematology in this case or other guidelines can really help with the advocacy part. As I was trying to say in my talk, putting these kind of issues front and center, like Ms. Giron de Hall was saying, like cure for now might seem unattainable. The Commission had the really ambitious goal of by 2040 having, if people really push and we work together, of being able to offer a cure to everyone. This is very ambitious and it will depend on many stakeholders. But for now, I think, as Ms. Giron de Hall was saying, the important thing is that we get patients the basic interventions that we know work and can improve their quality of life. And for that, we will need to, like Julie, you were saying, we'll need to strengthen partnerships and collaborations with all actors, including pharmaceutical companies and big agents such as WHO that can influence governments and put them in the right track. So that would be my contribution to keep working. And I think webinars like this one hopefully help to make these relationships more cohesive and get these conversations started to see how we can advance all together. So yeah, with this, I'll give the word to Professor Chilolo. I'm sure he'll have more to add. Thank you.
Thank you very much, Dr. Yaiza. Very important reflections and perspectives. Thank you very much. Welcome, Professor Chilolo.
Yes, thank you, Julie. Thank you, Yaiza. It's very important to insist on the key word that means solidarity. Solidarity that can involve not only warriors or people who are affected of sickle cell disease, but solidarity between different countries. You know that in Africa, a great effort is made so that we are working now in a consortium, the Sick in Africa consortium. This is an expression of solidarity between scientists. We hope that we'll be able to realize some of the recent progresses in the treatment of sickle cell patients working all together. I was in European meeting in Madrid, and we make a great advocacy about the possibilities to involve more and more African patients in clinical trials. Thanks to Professor Fumi Olopade for this very interesting example of breast cancer in which Black people were more and more involved. And this is one of the way to create and to strengthen the solidarity between patients, solidarity between patients and industries, solidarity with funders, as Yaiza has said in his speech. I think that the keyword is really solidarity, and to be also, I think, optimistic for the future. Thank you very much to all of you. Over to you, Julie.
Thank you very much for that reflection, Professor Shilolo, Dr. Yaiza, and Mr. Cesar. I think JP is here and he is available to make some comments. And we'll also put in the chat, there was a question from Richard in Kenya sharing about how he is a carrier for sickle cell disease and his sister has sickle cell disease and wanting to know how to join. So we'll put in the chat information about joining Sickle in Africa and being part of the different aspects of the community. I will now hand over facilitation to Dr. Vicky Nambaware from the DCC in South Africa to finalize this session. So really thank all of you for speaking, sharing your perspective, and welcome to JP, and over to you, Vicky. Thank you very much.
Thank you very much.
Yes, is JP online?
Yes, I am.
Fantastic. Over to you, JP. Thank you for joining. Would you like to present or just talk? Thank you.
Okay, I will just talk because right now I don't think my slides are ready.
Fantastic.
But basically, I was just going to share on my own experience as a warrior of 32 years. The main theme of my journey, if I can say, has been just trying to find my place, you know, in society, in the marketplace. A lot of what the world is based on systems and models. And so there's a family model if you want to start a family, there's a business model if you want to start a business, so to say. But for me, it has been a challenge to find a model for a male warrior in the marketplace, because one of the challenges is finding someone older, a male who's quite vocal about their experience, their challenges, and just a way to navigate through what it means being a male with sickle cell. The only thing that I found out during my journey is that there's almost like a roadmap to doom and gloom. Because growing up out here, when you turn 18, this and that will start happening. Most warriors don't make it past 25. So there's that roadmap for doom and gloom. But when I turned 18, everything they said would happen. Some of it happened, but I survived. And I was like, okay, let's get to 25. And then that was like the limit for me, reaching 25. And then I was 26 with no, so to say, plan or roadmap to follow, because we only hear the negative aspects of growing up with sickle cell, but very rarely do we have sort of like a superhero movie to follow. You know, we've heard stories of people beating cancer, surviving HIV, but for me, growing up, I didn't have like a figure to look up to and say, when I reach that age, I want to aspire to be so and so. So for many males that I've encountered, it's almost like we are navigating society, trying to find our place and trying to figure out things as we go. That's all I wanted to share today. Thank you.
Thank you very much, JP, for sharing. I'm not sure if there are any comments or reactions to what JP has just shared about the lack of role models within the sickle community, and maybe ways in which we can support as sickle cell stakeholders. I also see Solange wrote, if we unite and start making a noise as scientists, researchers, and advocates, especially in Africa, then it will force our respective governments to start playing a role in making our treatments access. Thank you, Solange. I'm not sure whether there are any comments on that, and Gada, great responses, but can we think of an African inclusive program to set a system in all our countries? I'm not sure if Gada and Solange, maybe you might want to expand on those comments verbally. Prof. Gada, is he still there? Maybe she's dropped off. And then Solange, are you still online? Would you like to comment or expand? Okay, I think you are now unmuted, Gada. Thank you.
Yes, thank you, Vicky. Thank you very much for the speakers. I would like to comment by adding that it would be great to have some kind of a unified program for all of us in Africa to follow, such a kind of African, not guidelines, but kind of a program of how to help our patients, to get them included, to train on advances in therapeutics, on new technologies, because everyone, I think, is in, not everyone actually, and I don't want to be using very strong words, but many of us are working in isolated islands. And it would be great to share even the tiny amount of information that we might have at different places together. And compiling them would be of great help to other countries. We've been discussing a lot about having some kind of educational programs. So if this would be a kind of applied educational program concerned with even one disorder, it would be a very good example and a very good start. These are my ideas I thought I would like to share with you. Thank you. Thank you so much.
Thank you, Professor Gada. I think a unified approach, standardization, and also sharing of experiences to make things and treatment provide better quality of care for patients across Africa and globally would be fantastic. And I think this is the vision that Prof. Chilolo had. I think I will let Prof. Chilolo comment on that aspect as well.
Yeah, I think that this great vision. As Professor Fumi said, solidarity is the key word. It's the way that we can move on in the management of sickle cell disease and access to different therapies in the sub-Saharan African countries. I coach this occasion to respond to a question that I've seen in the chat about the carriers AS and AC. Normally, the carriers are not suffering of pathological expression of sickle cell disease, except in very exceptional conditions where, for example, oxygen is very reduced, and they can also develop some complications linked to the renal complications and so on. I think that one of the problems we have in most of the African countries is the lack of correct diagnosis of sickle cell disease. It's the reason why I'm thinking that we need to obtain transfer of knowledge, but also a transfer of technology. That's very important for these possibilities of treatment we are looking for. Over to you, Vicky. Thank you.
Thank you so much, Prof. Chilolo. Yes, I think, the transfer of knowledge and technology is really critical. And I think even, experiences of just using RedCap to collect data, for example, has really made, the research quality and even analysis of the data much more bearable. So thank you for that, Prof. Chilolo. I'm not sure, Solange, if you now have your mic off.
Yes, thank you. It's Solange.
Oh, Solange,
And,
thank you.
And I'm from Sickle Cell South Africa. What I'm saying is, what the professor has been saying is, let's stand together. And I'm saying that, especially in South Africa, there's a lot of warriors that you get to meet now and then. But in hospitals, they still don't know what to do when a warrior comes along and has a crisis, for instance. So if we all combine as scientists, as researchers, and start making a noise and not just be seen as the warriors, because it's like, okay, we don't really have sickle cell in South Africa, so we are not going to hear you. But if all of us come together and start making a noise, then they'll be able to recognize, yes, there's this thing. Yes, there's research about it. This is what I can do in my hospital, in my public hospital, in my private hospital. And we can carry on that way to all other African countries as well. So what I'm saying is, let's find a way to be together and make a bigger voice, bigger noises, so that everybody can start taking notice and start seeing that, yes, there is a noise from research, from scientists as well.
Fantastic. Thank you for that input. I think it's really important, as Prof. Alopade mentioned, the solidarity is really important, because I think as a bigger body, you've got more impact. And I think it starts with, webinars like this to really get started in connecting people who've got the same vision and same drive in combating the disease. I'm not sure if there are any other comments on this, especially I think JP's comments about having male models and about having more support, possibly for males who are living with sickle cell disease. Any thoughts or ideas?
There's a hand up from Sarah Keita.
Fantastic. Thank you, Keita. If you can unmute, that would be great.
Hello, can you hear me?
Yes, we can. Welcome. Thank you.
Hello, can you hear me?
Yes, we can hear you, Sarah Keita. Welcome.
Yes. Hi, yes. I did want to respond to role models in general. Like, JP said, I think we tend to look at the dark side of sickle cell in general and don't look at those survivors and have them as role models so that people can see that it's a survivable disease. You can have children, you can live a full life. You just need the information and you need the proper care at an early age, be properly diagnosed at an early age, and then have access. And so that brings me to the second point that I wanted to make. We're talking here about solidarity and talking about ways to increase, information about it. We have a lot of information about how to cure the disease, and there's some, cures out there. And one of the things that was raised, and I think that we don't talk enough about in the scientific community, is the access to these cures. We tend to not talk about the issue of money in the scientific community and business development towards, research, more research. And this was something that Dr. Olopade raised. The family did fundraising so that there was more research around breast cancer. And so I think that in the sickle cell community, this is something when we talk about partnerships, and we should also partner with business people and entrepreneurs who think in a different way. And scientists, we tend to not do that. We shy away from the money talk and all of that. But if we're going to make the cure accessible to more people, if we're going to look for solutions that are durable solutions, then we do need to have some of those business-like minded people also as part of our consortia to help us think through how do we raise enough funds for the cure to be accessible to more people, and how do we raise enough funds for increased research for this disease and other diseases. Thank you very much.
Fantastic. Thank you so much, Sarah Kecha, for that. And I think this is really important to look at business models or even some of our research findings. How can we be prepared to turn some of these ideas into profitable ventures, which not only benefit research but also benefit the patients themselves. I think the issue about affordability of some of the curative therapies has come up several times during this session. And could that be a possible means of, if businesses and profit generation of ideas and interventions really feed back into making sure the patient's quality of life and quality of care is improved, could be something we could look at. It's interesting because we do have one or two companies that are going to be in later sessions tomorrow. So it would be interesting as well to get their perspective of how we can work together, researchers, patients, companies, policymakers, everyone towards the same goal. I'm not sure if there are any people who might have had experience with some business or spinning off some research ideas into business or profit generating ideas that benefit patients, or working with organizations that work towards either generating profit or lowering costs of care for patients. Welcome to any participants on this webinar who might have had that model.
Vicky, there's the intervention from Kironde.
Okay, fantastic.
Hi, can I? Yeah.
Sure.
Okay, yes. I wanted to talk about men as role models in the sickle cell community. Because we've always had this topic that we do not have enough men speaking up about sickle cell, men who are warriors, men who are caregivers. We do have doctors and researchers speaking, but we do not have many men who are directly affected by sickle cell speaking out. And I think one of the ways we can change this for future generations, or even for warriors, male warriors who are still quite young in their early 20s as teenagers right now, is empowerment of these people, of these boys, of these men, of these young men, telling them that living with sickle cell is not shameful. With girls, we tend to be quite soft with them. You're allowed to cry, you're allowed to express your feelings, but in society, men and boys are told that you have to show a solid face. You cannot be seen as weak. But with sickle cell, where our weakness is seen as something horrible and something we should not show, our strength also comes from embracing our weaknesses. And from our weaknesses, we, I don't know how to explain it, but from there, that's from my weakness, my weakness comes in sickle cell, but that's where my strength comes from. And that's where I've learned to speak about it, to help other people, to tell them about my experiences. And I've gained a community from it. And if we can tell young boys that you can talk about your sickle cell, you can express your pain, you can express your symptoms that are seen as shameful because other people are going through this, I think we will have more warriors talking about this. And I think we also have to get more fathers into the sickle cell community. We usually have mothers coming in for all the appointments for their children, even for their sons. But if we have more fathers coming in, more fathers taking the primary care of their children, where we see more of an equal household where both mother and father look after their children, I think we're going to have more men coming out and talking about their experiences as caregivers to children with sickle cell. And if boys can see their fathers talking about this illness, this condition, I think they will also be empowered to talk about it. But I think we need to give men in our community more space to talk about it, and we should not shame them for having to deal with sickle cell. It should not be, sickle cell is nothing to be ashamed of. It's a way of life for many of us, and many men and boys have to be told that it's okay to have it. It's okay to talk about it. Your power does come from your sickle cell, as long as with some weaknesses that you may have. So I think that's one way of empowering the men and getting them into the sickle cell community more. Thank you.
Great. Thank you, Esesa.
I agree.
Yeah, great. Thank you. Prof. Chilolo, would you like to come in?
Yeah, just a comment on what Esesa said. I agree with her. It's very important to involve more men in the sickle cell disease fightings that we are doing. And it would be a good thing to involve also some celebrities, you know, about the business and sickle cell disease. I think that we need to involve also the African people who is very rich. I just say an example in Nigeria. Dangote is one of the richest man. We plan to invite him in the next global sickle cell disease meeting in Abuja next year. This would be a great thing for us to involve some of the African leaders, African stakeholders that can be involved in this good adventure on sickle cell disease. Thank you to all of you for this very interesting and exciting meeting. Over to you, Julie. Vicky.
Great. Thank you, Prof. And we are looking forward to the meeting in Nigeria, as you mentioned. I think we're working towards that. I don't know if there's more details about the meeting. We can also advertise during the webinar series, just to prepare people for it. Are there dates already? Yeah, thank you, Prof.
Yes, we can share in the webinar the dates. Obi and Professor Ken are the co-chairs with me. We will share it in the webinar. Thank you.
Fantastic. Thank you, Prof. Yes, I also just want to check if there's anything burning in the comments, and I'll read those aloud. We will have 5 minutes before our next session. Our next session starts at 1:30. I think that hydroxyurea is a good option for many sickle cell disease patients. Thank you, Fethi. This is true. I think Professor Chilolo has done a lot of research around this, and one of the first clinical trials in hydroxyurea was actually led by Professor Chilolo. So if you've got questions about hydroxyurea, please do point those questions to him. I think the one was also about fathers from Eseza. Thank you. I also just want to acknowledge Nchankwi Cynthia. I think she's on the line. She was very instrumental in putting this agenda together. And I think she's been instrumental in also creating solidarity among the patients across Africa, especially through the Patient as Partners in Research working group that has been established. I don't know if Nchankwi, you might want to make a few comments if you've got a mic on, but thank you for pushing this agenda. Thank you. Great. She might not have access to a mic. So I think if it's okay, Professor Chilolo, we will take a 5-minute coffee break and then come back for the next session, which will really be highlighting some of the different consortia and different groups that are working in Africa, pushing the African agenda. Thank you very much.
Thank you very much, Vicky. You can just announce that in the next session, Professor Emmanuel Balandia and Professor Ambrose Wunkan will be the chairs. Thank you very much to all of you.
Thank you. Bye-bye.
Bye.
Yes, good afternoon, everyone. Welcome to the second session of the World Sickle Cell Day commemorations, which are being hosted by Sickle in Africa. Thank you for participating. We just want to highlight and good morning, yes, to others where it's still morning. We just want to highlight Sickle in Africa members who've made a great contribution to the Sickle in Africa, to the sickle cell disease field, who've passed on, and this is in memory of them. This includes Professor Kwaku Ohon from Pong, Mr. Paul Mutliwa. Those who were present earlier might have seen a video where he was featured. He was a patient advocate based here in South Africa. Miss Adebola Benjamin was a patient advocate from Nigeria who actually lived to be over 60 years old, and we had great learning experiences with her, and she also wrote a book. And Mr. Gaston Majandu, who was a data analyst for the Sickle in Africa Consortium, and especially for SADC. So maybe if people don't mind, we would just take a minute or two of silence to remember all the warriors who have passed on due to sickle, or those who've worked tirelessly to improve the quality of life and quality of care for sickle cell disease patients across the globe. Thank you. Thank you for that memory of silence. If there are others you've lost to sickle cell disease, you would like to be remembered during this meeting, please paste them in the chat box so that we can also incorporate them into our reports and hold them in memory throughout this webinar. We've got Dr. Siana Nkai, who is a co-PI for the SPARCO Clinical Coordinating Center. She will be chairing the next session as both Professor Ambrose Wonkam and Professor Emmanuel Balandier could not make it today. So thank you so much. I'll hand over to Dr. Siana. Welcome, Dr. Siana.
Hello. Hello, Vicky, can you hear me?
Yes, we can hear you. Thank you so much. You can go ahead.
Thank you so much. So greetings from Dar es Salaam. Just to say that we are here in person, the Sickle Cell Program, as well as the Clinical Coordinating Center for Sickle in Africa at Protea Hotel. Thank you so much for the opportunity to chair this session, which I think is very exciting on Africa Sickle Cell Disease Research Initiative. And without wasting time, our first speaker will be Professor Bates from London School of Tropical Medicine. I will quickly go through her bio. Professor Bates is a highly experienced clinical academic hematologist with additional postgraduate qualifications in research, tropical medicine, and education. She has over 35 years research experience focused on hematology and blood transfusion, including sickle cell disease. Her research experience incorporates public health, health systems, and capacity strengthening with a focus on collaborations with partners in sub-Saharan Africa. She also established the Center for Capacity Research at Liverpool School of Tropical Medicine, which is partnering with international research teams and research funders. And she is also has become a global leader in research on how to strengthen research systems. Professor Bates, we thank you so much for availing yourself for this session. Please go ahead.
Hello, everyone. Hi, my name is Dr. Nganda Moto. Okay, yeah. So, right, yeah. So, I am sitting in for Professor Bates, who is my video okay here? Who is unfortunately not available at the moment because of last-minute clinical duties. So, I was called in at last minute to help out with the presentation. I would say it has been prepared by Professor Imelda Bates and Professor Obiageli Nodu of University of Abuja, Nigeria, who are the two co-PIs of the PACS project. So for myself, my name is Dr. Moto Nganda. I am a public health physician, initially trained in Cameroon, and a global health researcher focused on collaborative implementation research for health system strengthening with focus on patient-centered care for people with chronic stigmatizing disease conditions at the Liverpool School of Tropical Medicine, where I work with the PACS project, or I work on the PACS project with Professor Bates, and who I initially said is unable to make it to this session. So PACS is, of course, an acronym that means Patient-Centered Sickle Cell Disease Management in Sub-Saharan Africa. It is an implementation research that seeks to get across the no-do gap between clinical mainstays for sickle cell disease and routine real-life practice, with focus in Sub-Saharan Africa and precisely taking place in 3 countries, that is in Ghana, in Nigeria, and in Zambia. Further, PACS seeks to make sickle cell disease management more patient-centered, which is management that considers a patient as an individual with particular health needs. Next slide, please. Right, okay, talking about clinical mainstays, we know that penicillin prophylaxis, hydroxyurea, and blood transfusion have track records of reducing morbidity and mortality in sickle cell patients and for improving quality of life. For example, we know that penicillin prophylaxis significantly reduces the risk of pneumococcal infections in children under 5. We understand that hydroxyurea increases hemoglobin levels, reduces anemia, lessens blood transfusion, significantly increases survival for sickle cell disease patients. We also know that blood transfusion is life-saving for acute complications and for prevention of the development or progression of chronic complications of sickle cell disease. However, these mainstays are not really implemented, or they're not widely implemented in Sub-Saharan Africa. And the question is why? Yes, we do know that there are several barriers to accessing quality healthcare in Sub-Saharan Africa, including things like poverty, low education, inadequate health systems, shortage of healthcare professionals, etc. But access to quality sickle cell disease is further limited by many other factors, like the stigma associated with sickle cell disease, cultural beliefs, negative attitudes of people, of both healthcare providers and communities or the patient's environment, which is somehow largely due to low sensitization around sickle cell. In the health system, we would also find barriers like failure to identify babies with sickle cell disease, difficult transition from pediatric to adolescent care, emphasis only being made on crisis management, while chronic management kind of lags behind. The dominance of sickle cell, clinical sickle cell disease care, which results in kind of lost opportunities to understand, to respond, or to mitigate these other barriers that I've listed above. So what does PACS do? We seek to understand why these proven interventions for sickle cell disease that saves lives in high-income countries are not widely used in Sub-Saharan Africa. What, according to patients, carers, and sickle cell disease healthcare providers, constitutes patient-centered sickle cell disease care? What constrains patients, carers, and sickle cell disease healthcare providers, and what constitutes patient-centered care? Sorry, what constrains these patients, and what constraints do patients experience when trying to access proven interventions? And what solutions could we devise by including patients and healthcare providers that can be patient-centered and sustainable to overcome constraints to both uptake of care and implementation of clinical mainstays? Next slide, please. Next slide, please. Sorry. Yes. Yes, thank you. Okay, so PACS has 4 main work packages, or 5 work packages. The first one is an epidemiology and mapping package, which will identify geographical and socioeconomic barriers and potential facilitators, of course, for access to healthcare by patients with sickle cell disease in our 3 partner countries, which again are Ghana, Nigeria, and Zambia. The second package is an action research cycle, which will deploy participatory approaches to identify and overcome localized barriers to drive both supply and demand-side factors affecting evidence-based patient-centered sickle cell disease management. We will also study the implementation and outcomes of the approaches we are going to apply at this level, with the aim of influencing policy and practice for sickle cell disease. The third package, which is a journalist engagement package, seeks to address gaps around sensitization and poor journalist or poor researcher engagement in sickle cell disease communication. And then the fourth package, which is really very important as well, is a capacity strengthening package for implementation research, which would include both individual and institutional capacity strengthening. I want to say that currently PACS has 3 PhD roles, 1 in each participating country. And centered around this is a massive, massive project management package. Next slide, please. So where are we heading to? Our overall vision is to improve well-being and health outcomes for patients with sickle cell disease in sub-Saharan Africa. And we want to make this patient-centered and evidence-based. We thus anticipate to have or to produce outcomes around patient-centered sickle cell disease care and evidence-based clinical interventions that meet international standards, around sustainable solutions to barriers in accessing sickle cell disease care with increased uptake in care, around sustainability network of researchers and institutions able to do and support high-quality implementation research for health problems, irrespective of disease focus, and an expansion into a multidisciplinary, multi-partner, Pan-African Center for Sickle Cell Disease Implementation Research. Next slide, please. So far, PACS is currently completing baseline epidemiological data and qualitative research that would feed into the action cycle packages. And we have also done the first stage of capacity strengthening on implementation research for country leads, who will then drive forward the action research or the action cycle phases of this implementation research. Thank you very much for listening. I want to acknowledge our funders as well, which are the NIHR at the National Institute of Health Research UK. Thank you very much. Sorry, are we there?
Hello?
Yes, I can hear you.
Thank you so much for your talk. Very interesting. I believe there will be some comments or questions. I will allow maybe 2 questions before we move on to the next speaker. I will also try to look if there are any comments on the chat, but really interesting to hear about what PACT does with a very centered approach towards the patients.
Thank you. Thank you.
I don't know if there are any questions or comments. Okay, so maybe we'll just encourage people to document their questions or comments through the chat, or also keep them for later. I believe there will be more time later for discussion and also to see how we can link all these networks together in terms of pushing the agenda of sickle cell disease in Africa. So for now, I will welcome the next speaker. This is Dr. Professor Ngasia, who is going to talk about the Sickle Cell Disease Research Network in Central Africa, REDAC. Professor Ngasia, it's really good to have you with us. We know that you are doing a lot of work in terms of sickle cell disease research and related activities in the Central Africa. You are welcome to give your talk.
Can you hear me? Hello?
Yes, we are here.
Yes, we can hear you.
Yeah, good. Thank you. Thank you so much, Dr. Siana, for giving me the opportunity to give this talk. First of all, I would like to thank the organizing committee to involve the REDAC Sickle Cell Network to this very interesting meeting about sickle cell disease. My name is Baron Garcia. I come from Democratic Republic of Congo, and right now I'm doing clinical hematology in Dakar and in Senegal. I'm going to share with you in 5 minutes our experience about the sickle cell disease, the work we call REDAC, which is also in French, Réseau d'études de la drépanocytose en Afrique centrale. Next slide. So the REDAC is an African network created in 2010 in Kinshasa by African researchers and also clinicians involved in the sickle cell disease. The idea to create the REDAC came after a very interesting meeting that took place in Brazil in 2009, which allowed those African people to think about a network which can try to help African researchers to work together. This is why REDAC is a dedicated network to fight against sickle cell disease in Sub-Saharan Africa. REDAC also includes some Americans and European researchers, both dedicated to sickle cell disease research. The main goals of the REDAC when we created this network was to promote a very strong collaboration between Central African country. You know, we have the haplotype Bantu, which has a very severe clinical expression, and most of our patients die before 2 years of age. This is why that was very interesting for us to collaborate together and to set up a network for harmonizing the management of this the disease. This is also for allowing patients to get a very good quality service come from those share of experience. Next slide, please. And based on these objectives, REDAC was created and legally recognized as an association in French, and where we have our office in Paris, but we have also administrative headquarters in Kinshasa in the Democratic Republic of Congo. As you can see in the slide, the other party, the right party of the slide. And we have a committee, organizing committee, which is led by Professor Leon Chilolo, and we have the Vice President, Professor Gonzalez, who stay in the United States, who was one of the pioneers who launched sickle cell disease screening in Gabon. We also have scientific committee, which is composed by African people and also some other people from France and overseas. Next slide. As I was saying, the REDAC was created to promote this collaboration. This is why we launched many symposiums and workshops. And our symposium took place every 2 years in the country of the members, and which is a very good opportunity to share experience with national actors of sickle cell disease, and allow also and help the host countries to get political and health authorities involved in sickle cell throughout the final resolution. So that means when we organize the symposium, it's not only for us to share experience to talk about newborn screening, infection, malaria, what kind of issues that we are facing with sickle cell disease, but the main importance is also to help this country to get the involvement of the national authorities, which can help them to promote very good strategy and continue to work about sickle cell. So this is why our final resolution is integrated into the national strategic plan of sickle cell disease. And since 2010, when we organized the first meeting of REDAC that was in Kinshasa, we organized the second that was in Libreville, and after Dar es Salaam, Yaoundé, and we came back again to Kinshasa. We traveled to Kampala. We went to Madagascar, when you can see a lot of sickle cell patients, and also with haplotype Benin. And that was very interesting to share the experience between patients come from haplotype Bantu and Benin haplotype also. That was a very good meeting. And then we came back to Kinshasa with online meeting which took place in 2021. And as you can see, the REDAC is like a real catalyst, which allows scientific and healthcare providers to continue to work about sickle cell disease. And during those symposiums, we also use it for building the capacity of local doctors, nurses, and to talk about the awareness of sickle cell that will involve also association of sickle cell anemia patients, and which is very important in our context to accept, first of all, the disease. As you know, in Africa, mostly in Central Africa, people think that sickle cell is only came from the mother, and they are most of them stigmatized. So this is why it's very important to talk about also awareness and to work together. Next slide. When we talk about the REDAC research and skill development, we have many projects, and you see we did some research about malaria. You know, malaria is responsible of high mortality among sickle cell anemia children before 2 years of age. And we also worked about COVID-19 infection, which was a big fear for sickle cell anemia patients. We also continue working together with one research association from China to promote about a pilot project of newborn screening by using genetic screening. And also we are trying to work together with many NGOs come from Europe and United States. As you know, REACH project, for example, we used hydroxyurea among our people. So the REDAC participate by putting the Democratic Republic of Congo among this group who experiment this medicine. So the REDAC is like a very a real catalyst which allow research and collaboration between African countries and also other countries. For example, we trying also to help the creation of REDAO in West Africa to continue to work together. So this is a very good opportunity that provides REDAC to strengthen this collaboration, South Africa cooperation in Central Africa. So next slide. As I was saying, the high mortality is observed in children with before 2 years of old. And if we can try to do the newborn screening and to start early antibiotic prophylaxis against infection, at least we can get the smile from the sickle cell child who can grow without losing his life. And this kind of smile can also help the doctor to touch a lion without having a fear. Thank you so much for listening to my presentation.
Thank you so much, Professor Garcia, for that talk, highlighting the work that you are doing in Central Africa Network, REDAC. Again, we will take questions and comments at the end of the session. Please continue to put them in the chat box or document them. Our next speaker was supposed to be Professor Mulder, but I'm told that she couldn't make it. And I'm aware that Professor Makani also couldn't make it for the meeting for this session. So I would like to welcome Dr. Vicky, who is going to cover the two topics, the sickle cell disease ontology working group and the sickle in Africa. Dr. Vicky, you are welcome.
Thank you, Dr. Siana. So I will share the slides just from my end. Great, thank you so much. Great. So it's a great pleasure to be presenting on behalf of Professor Julie Makani and Professor Nikki Mulder. And basically, I also just want to highlight again that this is in memory of many fallen heroes and warriors who've been fighting for sickle cell disease. And with the sickle cell disease ontology, you cannot separate the sickle cell disease ontology working group from the Sickle in Africa Consortium, because this is the sickle cell disease ontology working group is really what built the foundation for the Sickle in Africa Consortium. So to start off with, so that I can just give an idea of why this was started. When you ask what is a cell to a policeman, what would your answer be? Or what would they give as an answer? And if you ask the same question to a biologist, what would their answer be? And if you ask the same question to an engineer, it would be a totally different answer. And what I'm trying to highlight is that when you're working with different people who sometimes are working towards the same goal, one word can mean different things, or multiple words can actually mean the same thing. And in the same way, we wanted to start off by making sure that all sickle cell disease stakeholders speak the same language or understand each other, so that communication, collaboration, and even the systems that we use are exchangeable due to a common language and a common way of communicating in this field. So the sickle cell disease ontology, the first meeting was held in 2016 in Cape Town, and there are various meetings, about 4 of them, which were held, 5 of them, in fact, one just after COVID, which were held to really try and create the largest knowledge base of sickle cell disease in the world. And this was achieved, and this also brought the community together and to even show funders and other stakeholders that we can work together towards a common goal using a common language. And the main product, as mentioned, is the biggest knowledge base of sickle cell disease. And how we categorize this was that there's a core, a root, which describes the hemoglobinopathies. We then go into various classes, disease modifiers, gene product. You actually, if you go through the entire ontology, you understand the disease from where it comes from to diagnosis to therapeutics. And this is openly available, free of charge to anyone. We have this ontology in English. We have it also in layperson language. And some of the terms which have been translated into layperson so that anyone can understand the ontology terms, or patients can also use them, has also been incorporated in a mobile health application. We have also translated the ontology into French, and we are busy working on a Portuguese and a Swahili translation. The next phase of the ontology, although it's a living, database, you can make updates, you can request terms to be added, you can request for definitions to be updated. And the next phase, which we are currently in now, is application of this ontology. Because not only did we define the knowledge base of sickle cell disease, but we also have a framework which can be used to inform the creation of data elements, which are collected for research, to also standardize patient clinical management systems, to also inform machine learning algorithms, which are based on, which are used to harmonize data, existing data, so that you can promote and facilitate collaborations across, on existing data from different stakeholders. And it is also a portal where we've been cataloging ethical, legal, and social implications. And for sustainability, we've realized that a lot of people do not access the ontology. And now we are working on a sickle cell disease ontology book, which will be downloadable and usable by anyone. And another factor is that the sickle cell disease ontology is also informing development of a biorepository system, so that we can also standardize the collection of samples across different stakeholders. So once the sickle cell disease ontology working group was set up and is still ongoing, which is open to anyone to join, the membership spans across 80 countries, and it's not only in Africa, the membership, it's also in Asia, in America, in the UK, and even in Jamaica. And all these collaborators are really sickle cell disease stakeholders working towards the same goal of improving the quality of life and care for sickle cell disease patients. In 2017, the NHLBI, the NIH, then funded what is called the Sickle in Africa Consortium. Initially, there were only 3 sites where activities were being supported by Sickle in Africa, but now we are in 8 countries, and we hope in the near future, Sickle in Africa will keep on expanding. We've got countries which are highlighted in red and blue, and we've got a data coordinating center based here in Cape Town and a clinical coordinating center based in Tanzania, which is led by Professor Julie Makani and Dr. Minja and Dr. Siana. As you can see from our organogram of the consortium, the clinical sites are really key because they do all the groundwork. We also have a scientific advisory board and patient representatives who advise us and who participate in our meetings and give us input and direct most of our activities. We also have 2 co-chairs, Professor Leon Chilolo and Professor Olopade. who are really instrumental in guiding us and giving oversight independently, so that we've got leadership that is also knowledgeable and experienced in the issues that we're working with. And as mentioned, our funder is in the LHLBI, the NIH, the US government, and the sites are Ghana, Tanzania, Nigeria, Uganda, Mali, Zimbabwe, and Zambia are one site, and are led by 3 PIs, with the main PI being Patients Corner. And the Data Coordinating Center, as you can see, is led by Professor Ambrose Wonkam and Professor Nicola Mulder. Before Sickle in Africa started, we did an inventory of all sickle cell disease registries. It's well known that sickle cell disease registries are key to transforming any disease area. Once you've got a registry with masses of patients, you can really start understanding disease progression. You can look at trends that you could not look at when you're looking at a small cohort, which is in country. When we did this analysis, we realized that if you see on the map, the blue dots are where all the sickle cell disease registries were located. And in red are the areas where sickle cell disease is most prevalent. And as you can see with Sickle in Africa, one of our key objectives was to create a sickle cell disease registry, which would cater for all the countries that are most affected by sickle cell disease. And just to highlight that, we targeted to have recruited 34,000 patients by the end of 2026. And already we have recruited 34,000 patients in our registry in the various countries that we are in and that we're funded to be in. And the current enrollment is actually over 34,761 patients in the registry. Another key achievement is that while we were collecting data for the registry, we were informed by the sickle cell disease ontology to create standardized data elements. These data elements are freely available for anyone to use who would like to start a sickle cell disease registry. And this is another output from our work. And just to mention that this is a participatory work where all sites and all members contribute, and everything is freely available. And another factor is that we have worked hard and learned on the way about patients, including patient as partners in our research and in our activities. And as you know, this is a learning process. And at the moment, we've got a working group that we support, which is also supported by the LC Hub, led by Dr. Cynthia. And this working group is working on creating a framework for equitably engaging patients as partners in research. Because when we started, we just had a vision that we would like to partner with patients, but how to go about that, we didn't have a framework or tools of how to do that effectively. And we always try and support that patients have their own voices, and we try and push for that in some really major journals, including Nature and Lancet Hematology. Another key achievement, which was really being driven by the Clinical Coordinating Center from Tanzania, is the SPARCO standards of care for sickle cell disease in sub-Saharan Africa. In the first session, there was a lot of talk about standardization of care and quality of care. And this is just to highlight that there are some, and I understand Dr. Vivian, who's been leading this, will speak more about this in some of the upcoming sessions. As a cross-consortia, we also support research. We are really driving for knowledge generation by publishing engagement, and making some of this material publicly available. We've got over 30 standard operating procedures in research that are also freely available. We've got over 10 guidelines and policy documents which can be adapted or adopted by any other consortia. We've got pipelines and codes and training, and obviously the Sickle Cell Disease Ontology Working Group. Some key achievements we've accomplished over the years are also highlighted and on this roadmap. And some key achievements or objectives that we want to highlight is a biorepository. We're in the process of creating a biorepository from some of the patients that we're recruiting so that we can really enhance research. We also launched cohort and implementation studies, these will also be highlighted in detail in upcoming sessions, and these include newborn screening, the malaria observational study, the pharmacogenomic study, and the penicillin implementation study. So I think that's about it on the Sickle in Africa Consortia. I welcome the PIs to really participate in the panel discussion, as I am only just presenting this on behalf of speakers who couldn't make it today. Thank you for listening.
Thank you so much, Dr. Vicky, for highlighting the work done by the Sickle Cell Disease Ontology Working Group and what we do within the Sickle in Africa Consortium. Again, we will have the discussions at the end of the session. Now I would like to welcome Ms. Nabela. I hope she's online. She's going to talk to us about doing sickle cell disease research from a patient perspective. Nabela, you are welcome.
Good morning, good afternoon. Thank you for the introduction. I'm just waiting for my slides.
Nabela is the Executive Director for the Sickle South Africa Support Group. Please go ahead.
Thank you. So I'm going to be speaking about some of the challenges and learnings that I experienced while doing my research in sickle cell disease. You can move to the next slide. I did a mixed method study for my master's research titled Patients' Perspectives on Emergency Care for Sickle Cell Disease in South Africa. Starting off with the very dark reality of the geographical disparity between high resource and low resource settings, where there's a limited exchange of knowledge and best practices across the borders. Studies from the USA determined the life expectancy of individuals with sickle cell disease to be 2 decades shorter than those without sickle cell disease. And the under 5 mortality of sickle cell disease patients in sub-Saharan Africa has been estimated to be greater than 50%. With that being said, the mortality rates in sub-Saharan Africa match the mortality rates of the USA in the 90s. That's how behind we are in trying to catch up and change what sickle cell disease is to the patients in Africa. The lack of literature in African countries, it was very difficult for me to compare, and I don't know whether it was because the literature is not being done. Is it done in isolated islands, or is it just a lack of published research? I can compare patient experiences, with just echoing what Vicky said, with the standardization of terminology in sickle cell disease care, and the standardization in treatment protocols. Thus standardizing this would not only benefit data, but also treatment and clinical outcomes for patients. There was a lack of SOPs, and creating some of these to translate both in your high resource and your low resource settings would be beneficial, because it ensures comparability and reliability. It enhances data sharing and collaboration, and it allows for the adoption of international guidelines all of this could come together and create short-term projects, but that has long-term impacts in research and to patients as well. Next slide, please. So I chose a few of the patient quotes from my study in line with just 3 of my themes. And I just wanted to do this to highlight why sickle cell disease research is important. With regards to knowledge and education, patients mentioned that they were so disappointed because the same healthcare professionals that they were going to seek care from were asking them what sickle cell disease was. They said that the healthcare professionals couldn't even spell it, and they kept saying that it's anemia, and anemia doesn't cause pain like this. Patients also held hope that they could help educate the doctors and the relevant departments and even advocate to the community to be aware and know more about the disease in order to get treated better. Patients called for having patient-centered pain management strategies. They felt like the triaging system is flawed for hematology patients, that they're assigned with a number or color that's not true to the pain they feel. It's not true to what they feel in the moment. And just the triaging of patients is where the fault starts. And with research, it also highlighted how limited pain scales are in assessing the true reflection of patients' pain levels. And patients also called for having conservative methods of pain management that would work for lower resource settings, like the use of hot water bottles while waiting to be seen. In terms of care coordination, patients said that just something the government should help with patients who must work frequently. A patient noticed that with their last employers, they gave him less and less hours to clock, and then they got rid of him. That he then became more sick with stress and he couldn't seek care. And then this just shows the knock-on effect an illness has towards health, their work, their living circumstances, and not being able to seek care as well. We also assessed the use of the emergency tag bracelet, but patients said, and this aligned with Western research, that the emergency tags didn't really help because healthcare professionals didn't know what the condition was. So even though they see the name of the condition, they don't know what it is, and therefore it's not helpful calling for an extension support tool or online resource that can be linked to the emergency bracelet. Next slide, please. I think all of these quotes from the patients draws on the need to understand the disease, the mechanisms, the genetic factors, the complications, genetic modifiers, to understand why do even some people who carry the sickle cell trait present with symptoms where others don't. In terms of developing treatments, in terms of gene therapies, reducing the bone marrow transplant-related risks, hydroxyurea, why is it so effective for some patients but causes such adverse reactions in other patients? To use technology-driven approaches like mobile health apps to track symptoms, medication, pain episodes. This can lead to personalized care and electronic healthcare records, SOPs, data coordination. And once again, how do we achieve this in low resource settings that might not always have the best network connection or internet? This leads to improving the quality of life of patients, to address the psychosocial issues, the mental health, and connecting patients to support systems. And there's an influence on policymaking to inform healthcare policies and resource allocation, screening programs, data to show the economic burden that can prioritize policies, and then again, standardizing research and guidelines. Next slide, please. I just end off with a call to action to have more conversations like these, workshops and conferences for regular sickle cell disease focus events to share findings and innovations, forums for continuous dialogue so that we can keep motivated, keep the passion, and keep trying to create the change, to encourage publication of research in open access journals, for networks to be collaborative, to establish global and regional research networks for sickle cell disease. I think Prof. Gada spoke about doing isolated research, interdisciplinary teams to combine expertise from the researchers, hematologists, genetics, and psychologists to build on public and private partnerships and leverage resources from both sectors. And we can't do this without the community involvement because patients are the experts in their own conditions. We need to engage them and the caregivers in research design, implementation, and to ensure that the research is both culturally and clinically relevant. And finding opportunities to advocate for increased funding and resource sharing among different institutions. While each of these aspects are important in their own right, they collectively create a comprehensive and effective framework for advancing sickle cell disease research and care. You can go on to the next slide. Thank you so much. My email is there for any questions.
Thank you so much, Ms. Nabela. I think we keep hearing more and more the role of to ensure that we have engagement of patients as research partners. And it's really good to hear all the thoughts and research questions that are important from the patient's perspective. So we have come to the end of the talks. So we have heard from PAC.
Sorry, Sienna. I think we haven't heard from Arise.
Are they present?
Yes, please. Thank you.
Okay. All right. Yes, you are welcome, Professor Bonifazi. We can't hear you. I don't know if it's just us.
What about now? Is it
Yes,
better?
now we can hear you.
Okay.
Okay. Okay, I switch it to another microphone. Thank you. Thank you for your kind invitation. It's a pleasure to present ARISE, the African Research and Innovative Initiative for Sickle Cell Education, to improve research capacity for service improvement, which is one of the common aim that has been already discussed today by my colleagues. If you can go to the next slide, I will go through project and in the initiative. So ARISE is a project funded by the European Union, launched in 2019 with two main aims. First of all, to establish and to have in place a universal newborn screening and early infant diagnosis program in sub-Saharan countries, and to build African personnel capacity to achieve excellence in science and a sustainable research capacity, using a number of sickle cell disease projects as living laboratories where capacity and expertise, skills are used and improved. This project has been built on 5 main pillars. That is a training program to create a common base of knowledge, to expand the knowledge of the participants in the program, and to better sustain activities within the second pillar, that is joint conduction of research. We know that working together usually improves the outcome, and this is more and more effective within the field of clinical research. But then we also need to be able to translate into practice the results of the research, and this is a task for the implementation science and its principles that can help us in doing that. Moreover, we have a built-in return mechanism that is the concept requested by the European Commission and based on the idea that all those participating in the training program should have been able to transfer back to their own institution the acquired knowledge. And finally, networking, which is the clue to stay together, to improve ourselves and achieve better outcomes in the future. This project involves 19 institutions from 11 countries in Europe, in Africa, and in the US. And the funding mechanism is an extensive staff exchange program. We have been able to fund more than 450 person-months exchanges of personnel of different categories: researchers, health professionals, and caregivers. Next slide. With the project is now approaching its end. In October this year, and by that date we will have more than 140 staff members whose ability will be improved in one or more of the areas of the implementation science, laboratory skills, epidemiology and statistics, clinical management of sickle cell disease, genetic counseling, transcranial Doppler, research protocols development, and communication. This has been achieved through the inclusion of the persons in the staff exchange in the activities of several work packages designed with the collaboration of all the partners. Next slide, please. So, as said, one of the pillars was the training. And as it happened to almost everyone, we were forced by the COVID pandemic to move online most of the activities. And we used the 2-year period where all the exchanges were frozen by the pandemic to deliver a number of of virtual training replacing the on-site one, which restarted at the end of the pandemic. So we were able to organize and to deliver training about clinical management protocol for sickle cell disease, how to use transcranial Doppler, how to provide genetic counseling, how to improve the work in a laboratory environment. All this training has been functional to the conduction of research. Next slide, please. Where some of the main topics of ARISE have been used as research needs and translated into research protocols. After an initial pilot phase in some of the countries, we have been able to finalize all the research protocol and submit them to the ethics for an ethics application. And now we have a number of studies that have been completed or are ongoing, including a gap analysis of the needs of persons, of laboratories in a country in terms of needs for sickle cell management. An analysis of country-specific ethical and legal requirements for the processing of personal data and the handling of human samples, so that it has been possible to support all the other research projects that were based on the processing of data or the handling of human samples, providing information about the requirements to be satisfied. We have a study to assess the availability and accessibility of health technologies to manage sickle cell disease complication, which is ongoing. A first pilot was run and completed in Nigeria. Now we are expanding the same study to the whole country. And the same is ongoing in Lebanon, in Angola, and in Kenya. So by the end of the project, we will have the preliminary data ready for dissemination. We are analyzing the needs of sickle cell patients and healthcare workers working with those patients, which is important and which is another common theme I already heard today. Epidemiological surveys and data collection to improve knowledge about the disease burden. Research about the assessment of genetic and hematological modifiers of the disease severity. And this is in line with the first main aim of our initiative. Several local newborn screening programs have been implemented and conducted in Zambia, in Angola, in Nigeria, with the aim to expand to the whole country. And this is for sure a very important achievement of the project. And the plan is now to continue with RISE after its end, to keep the whole network together and link it with the other existing initiative. And the next slide is just to say thank you, everyone. These are moments of the life within the project during the training school, the meetings, and the laboratory activities that have been completing during this period. So thanks a lot. Ready for any question.
Thank you very much, Professor Bonifazi, for the talk on ARISE. So we do have about 15 minutes for comments, questions, and discussions. So I will welcome the floor. I think we have had very interesting talks showing the different networks that we have in Africa doing different activities on sickle cell disease. I think we have had a number of overlapping themes, research on disease manifestation, research on implementation science, and epidemiology of sickle cell disease, but we have also seen almost every network talking about skills development and capacity building. But also we have had an angle from the patients and what they think is important in terms of research areas that will improve healthcare. So I would like to welcome any questions or comments. Anyone, please feel free to ask. Also looking at the questions that have been put in the chat box. There's a question from the chat from Mustafa. I don't know if Mustafa, you want to talk. Hello, can you hear me?
Oh yeah, hello.
Yes, you're welcome to ask your question.
All right, how are you? Yeah, my question will be straight. And anyway, thank you to all the presenters for the excellent presentation. So my question will be straight. I was wondering, the SADC, where the sickle cell registration is taking place, the registry is not covering the area like Gambia and Senegal. We know from the data we have, we know that sickle cell is highly prevalent in that population. I'm currently doing my PhD on sickle cell, looking at genetic modifiers in that population. So I'm a student of University of Ghana, so registered on the WACBIP.
Sorry, Mustafa, we can't hear you very well. I don't know if you can speak up, but I will also try to ask the question on your behalf. So I think Mustafa was just curious to know why Gambia is not represented in the patient population. Maybe anyone can respond to that, but I think from some of the talks we have heard, like the Sickle Africa, we are hoping that there will be expansion of the work that we are doing across Africa, and I think maybe that will be the similar sentiment from the others, but I will let others to also answer or address this question. I think the same comment came from Gada, who is saying, I hope the map would be expanding. So I think that is also a similar comment. So I would welcome.
Can you hear me now?
Yes, we can hear you.
Oh, yeah. So just to elaborate on my question, I was wondering why the area like Gambia and Senegal were not covered in the sickle cell registration cohort. I saw country like Ghana. I'm currently working on sickle cell. I'm a PhD student working on sickle cell. You're using Gambian population.
Okay. All right. Thank you so much, Mustafa. I hope you could hear my response, but I will also let people to respond. I don't know if Vicky or anyone else would also want to respond to that.
So thank you, Mustafa. I think, when we started off with the sickle cell disease ontology, the plan was to get everyone on board, whoever is working on sickle cell disease. And sometimes what is limiting are resources. So what we have done, in spite of not having enough resources, is we've also created or we've continued to support the sickle cell disease working group, which is open to anyone, even if they're not funded by the consortium, so that you're an affiliate. But at the same time, there is also an opportunity to register data. I'll just put it on the screen now. To register data. So we've got a registry of existing data, because the data that we've been creating within Sickle in Africa is data that is created, based on the standardized data elements, but we are aware that people have got existing data they've been collecting. So we've got an online registry where someone can actually register to say, I've got this metadata. You don't have to upload the data, just to describe a bit of your data. And we've got a tool that Wilson and Gaston, the one of our analysts who passed away, created, which allows for harmonization of data elements from existing studies. So if you're interested in being part of that, please do sign up. And when funding calls come, then we can look for more resources. But otherwise, the sickle cell disease ontology working group, anyone is interested who's interested and is looking for collaborations can join. I've just shared that link with you.
Okay.
Thank you.
I will try to access the link.
Thank you so much, Vicky. I think we had another comment from Victoria on presentation that was given by Ms. Nabela. And her comment was importance of having multidisciplinary team, which includes nurses and social workers. She believes plays significant roles in care or support for sickle cell patients. I think we all agree on that. I don't know if Victoria, you wanted to add anything on this?
No, I just want to make a point that whenever we're putting our teams together, whether it be research or clinical development, that we make it a true multidisciplinary team. And this is very important, even when we're conducting any training or planning training. Nurses and social workers are essential because they're the ones who see the patients most and can provide resources within the system and outside of the system. Thank you. Great presentation.
Thank you very much, Victoria. And then we had a question from Michael. His question was, from the epidemiological perspectives, what are the best laboratory technologies for the early screening and detection of sickle cell disease in the resources limited countries? Maybe I will welcome, I don't know if we have Kutala on the line, but I can start. So I think at the moment we have different ways of screening for sickle cell disease. The main one and the one that I think most people are pushing for is having newborn screening in services across Africa. And conventionally, we have been using HPLC and isoelectric focusing, IF. But at the moment, we are also exploring the use of point of care tests that are out there, which we believe will increase the access and also be useful in terms of resource limited countries. I don't know if anyone online would like to add on that.
Hi, Dr. Siana, it's Kutala here. I think you've mentioned all that we can explore in limited resources, but we have a molecular diagnostic method, which is completely cheaper. And now companies have created enzyme that can digest your fragment within 5 minutes. So that means you don't need electricity for you to digest that for a long time. So we have that as well that we use in our molecular laboratory.
Okay, thank you so much, Kutala. I don't know if we have any other comments or questions. We still have about 5 minutes to go. I think maybe one of the main takeaways from this session is that we have really seen a lot of work being done across Africa with different networks. And maybe one of the things that we may be able to do as an action point from this meeting is really to map the different activities that are being conducted by different networks and see how we can leverage across these and also share resources, but also share research findings. Yes, Professor Makani, you're welcome.
Hello, so thank you very much, everyone, for the presentations. Really valuable to learn from each other and try as much as possible to come together so that we learn from each other, we collaborate, and we share resources so that we don't duplicate, we don't replicate. I also wanted to emphasize one of the comments that has been made by Dr. Vicky as well as the other presentations or the other presenters, is really that this is work that is done by many, many people from different perspectives, whether it's patients, scientists, healthcare providers, the public, academics, and really recognizing that in order for us to succeed, it's really emphasizing the importance of coming together, working together, and things not just being dominated or focused by one or two individuals. So I really just wanted to kind of thank everyone within Sickle in Africa, within ARISE, within sickle cell disease ontology, and the many, many other networks, REDAC, etc., that we know of, and more that have not, that we'll be presenting and that we're working, is really solidarity, coming together and working together. So thank you very much.
Very much, Professor Makani. So if there are no more comments or questions, back to you, Vicky.
Thank you, Dr. Siana, and thank you for this really insightful patients. I'm also just thinking, I think there's another question, Dr. Siana.
There's a question from Nyararo Mano. This question is, how do I contribute my work to sickle in Africa? I've carried out a study in newborns using hemotype C point of care. still working on the validation work. The main challenge is funding. Okay, thank you so much for that question. I don't know if we have Professor Obi online. Professor Obi is the principal investigator for the newborn screening study, leading the study, the newborn screening study across the Sickle in Africa consortium. Don't know if we have Prof. Obi online. If not, maybe I can also I can comment. So within the Sickle in Africa, we are also conducting a study on validating or evaluating the use of point of care test, and this is hemotype C, particularly on dried blood spots. And this is because we see that in order for us to be able to increase access to newborn screening, using dried blood spots, which are accessible or can be managed very easily, even in limited resources, will be easy. And also coupling that to a point of care test like hemotype C. So I think, as Vicky had already alluded, that you can join the Sickle in Africa, and we can also share the work that you have done. I think it's good to continue to pull this evidence, as we say, working together, so that we make this point clear that we can use different tests for newborn screening. Vicky or anyone else, please feel free to comment.
Yes. Thank you, Dr. Siana. I'm wondering whether Prof. Chilolo might also have some words to comment, especially given the upcoming meeting in Nigeria next year.
Yes, thank you, Vicky. I would just like to emphasize the need to work all together and to make a bridge between the Francophone countries and the Anglophone countries in Africa. It's the reason why I'm thinking that by the end of this webinar, we will try, as you have suggested, to have a map of all the different networks and to try to make to facilitate the different contacts between these different networks. And these will allow us to mobilize financial resources. We need to work all together for that. Thank you to all your participants, and thank you to Vicky for giving me this opportunity to give these few words. Thank you.
Thank you very much, Professor Chilolo. So back to you, Vicky.
Thank you, Dr. Siana, for chairing, and thank you for the participants for the lively discussions. We'll now have a 5-minute break before we go to our last session. So this 5 minutes break will end at 3 p.m. The next chair after this will be Dr. Kwona, the principal co-investigator for Zimbabwe-Zambia SPACO site. Thank you.
Okay. So welcome to our last session for the day, which is the session 3. My name is Dr. Patience Kwona. I am a senior lecturer at the University of Zimbabwe and also a pediatric hemato-oncologist from Zimbabwe. And I hope we will summarize and finalize our wonderful webinar today with an exciting session that's coming. We have got 4 speakers. To say that my heart sank as I listened to the first session. The stories of the sickle cell disease warriors were quite overwhelming, filled with sad news, as people choose to focus more on challenges than on the hope and the life-saving interventions we all know exist for sickle cell disease and are available. And there is the obvious inequity that is around accessing sickle cell disease therapies, particularly for our patients in Africa. And obviously there's a need to be more inclusive, including men in our psychosocial programs that support sickle cell disease warriors. Then as we were listening to session 2, we know that there are many low-cost interventions that are available for the patients, but I think what is more exciting is the collaborations that exist in Africa to try and address the problem of sickle cell disease for our patients. So now we are going to hear more on variability of sickle cell disease severity and morbidity and mortality. And our first speaker is Professor Gindo. He's a professor of hematology at the University of Bamako in Mali, and also a professor of PharmD. He holds a PhD from the University of London and a postdoc. He did his postdoc on malaria and vector research. He's a member of the French Society of Hematology and an allied member of the American Society of Hematology. Currently, he's leading all operations of the center, Sickle Cell Disease Center in Bamako, Mali, and is the site lead for the SPACO Mali clinical site in the Sickle in Africa group. Professor Gindo, you can go ahead with your talk.
Okay, thank you very much, Dr. Kwana, for this wonderful introduction. So let's wait for my slide. Vicky, can I have my slide?
Prof. Gindo, yes, I think we'll just give a few minutes to Wilson to put them up.
All right.
Patients, not sure if we can go to the next speaker and come back to Prof. Gindo while we sort out this technical glitch. Thank you.
Okay, so I think I don't know if Dr. Jack Morris is ready to speak.
Hello.
Or,
Hi,
okay.
hello.
Hi, Jack, how are you?
Hi, Prof. I'm good, thank you. How are you?
I'm okay. Are you able to share your slides? Okay.
Oh, so Wilson has shared them.
Okay, all right.
cool.
So let me just introduce you. So Dr. Jack Morris is a data analyst from the Data Coordinating Center and supports the Sickle in Africa Consortium research projects in various ways. So Jack, you can go ahead with your talk. Then after you, I hope Prof. Gindo's slides can be uploaded so that he can speak. Thank you.
Cool. Thank you, Dr. Corner. Yeah, so I am a data analyst for SADC, the data coordinating arm of the Sickle in Africa consortium. I recently transitioned to a role as a consultant rather than a hands-on analyst. So you'll be seeing less of me and more of people in our team as the consortium progresses. But this is work that we did over the last 2 years or so that I wanted to describe to you today, where we were doing a whole cross-consortium analysis of the first phase of the Sickle in Africa Disease Registry. So I suppose the initial question to ask is why a disease registry in the first place? I know that people have, in this webinar today, have been speaking at length about the Sickle in Africa Consortium and the registry itself, so I don't want to hang on to dwell on that too long. But it seems necessary that we would construct a disease-specific registry for sickle cell patients in Africa specifically, because not much is known about levels of treatment for sickle cell patients on the continent. Not much is known about complications from an epidemiology standpoint, and not much is known about where the patients actually are also. And so as a means to kind of to gather this information and to help connect patients to care, this registry was began. And so, oh, sorry, next slide. Oh. Hello? Sorry, have the slides disappeared for just me? Or
they have disappeared for everyone, but I think you can continue speaking. They may be experiencing some challenges where they are beaming. Yeah, they're coming back.
Here we go. Okay, cool. Thanks, Wilson. Thank you. So when the registry was first conceived, the consortium decided on some targets for how many patients it aimed to enroll in the registry by the end of phase 1. And these targets changed from country to country depending on things like the prevalence of sickle cell in that country or in that region, and then other logistical concerns. As you can see, Nigeria, having the highest prevalence of sickle cell disease in the consortium at the time, had the highest recruitment target of 6,000 sickle cell disease patients. So phase 1 of the registry data collection lasted from around 2017 to 2021. And you can see by the end of the data collection, the targets were very well met. In that final column on the right there, you can see that the final recruitment numbers. And so we ended up with, at the end of the phase 1 data collection, a registry of more than 13,000 patients. So note that the ongoing data collection, the ongoing patient recruitment is now part of phase 2, and that data will become available to us in time. Next slide, please, next slide. So here in this figure, you can see the recruitment rates for the registry across the years of phase 1, starting towards the beginning of 2017 and then ending in 2021. The black dashed line along the top shows the overall recruitment numbers for all the sites or countries combined. And then each colored line shows the recruitment rates for the individual consortium countries. So one thing you might notice, for example, is the sharp peak in the green line, so the recruitment line for Nigeria, which is centered around towards the end of 2019. And this peak is there because at that time, around that time, the Nigerian SPARCO hub recruited a large number of new sites across the country to help boost its numbers and boost its coverage and impact. And so a lot of different sites joined the project around that time, and you can see there's a peak in recruitment numbers there. Next slide, please. Cool. So the recruitment was done across multiple facilities within the 3 consortium countries. You can see on the left, there's an outline of Ghana, and those 2 black dots there represent the 2 enrollment facilities that were associated with the Ghana Research, SPARCO Research Hub. They're both located in Kumasi, in Ghana. In the center, you have, this is an outline of the country Nigeria, and each black dot again represents a facility that was recruiting patients into the registry during phase 1. You can see the sharp, as a densely populated region of facilities around Abuja. that's dead in the center of the country there. And then on the right, you can see the outline of Tanzania, which we've depicted in blue. And again, each black dot represents the location of a facility. I would like to mention before I move on that while the dots in Ghana and Tanzania are relatively sparse with respect to the central Nigerian country, as you can see, these dots represent facilities that actually service a large portion of the country. So for example, we recruited patients into the registry from almost all geopolitical regions in Ghana. And in Tanzania, you can see this dot in the top left in the Mwanza region actually was a facility that serviced patients from across many different regions in that part of the country. So the northern and the lake regions specifically. Okay, thanks. Next slide, please. Cool. So the first thing we did when we were analyzing the phase 1 registry data was to look at how many participants within the registry were of HBSS. So we were basically looking at the genotype, the sickle cell genotype distribution. And you can see this plot here that the majority of patients, if I look at the bottom panel of that plot, the majority of patients recruited into the registry were HBSS, so sickle cell anemia patients. For Nigeria and Tanzania, that was about 99 to 100%. And then for Ghana, there was a significant portion of patients who were actually HBSC. So that's reflected in this plot. You can see at the top panel there, HBSC is around 33% for Ghana. We also observed HBS beta thalassemia patients within our registry as well, but all of the prevalences fell below 0.01, so very, very small numbers there. Next slide, please. So the next thing we did was to get a basic assessment of the levels of sickle cell disease treatment coverage that we found across the participants within the registry. So we found, for example, at the consortium level, that 1 in 9 sickle cell cases were using hydroxyurea at the time of enrollment. That number is actually very variable when it gets to the country level. So for example, 21% of patients in Ghana are estimated to be on hydroxyurea, whereas only 8% of patients in Nigeria are estimated to be on hydroxyurea. If we look at the other medications that are typically classed as treatments for sickle cell disease, you can see again a significant amount of variability. For example, 99% of patients at the time of enrollment in Ghana were using penicillin prophylaxis, compared to only 6% of patients in Nigeria for the same treatment. So this speaks to as we discussed in the beginning, a wide variety of coverage levels and a lack of information really about this coverage also. Okay, next slide, please. So once we did a baseline assessment of the registry, we began to ask specific research questions that we could answer with the data from the registry. So the first one we asked was, are patients put on hydroxyurea as soon as they're diagnosed? And we wanted to answer this question from a statistical perspective and looking at the consortium as a whole. So what we did was we built a regression model using the data from the registry to answer this question. And next slide, please. So in this plot, you can see the predictions from the best fit regression model that we drew. It's a bit of a confusing plot, so let me take a few seconds to explain it. Each panel represents a different age at enrollment for a patient. And then along the x-axis, you have the age of diagnosis of sickle cell disease in years of a patient. And along the y-axis, you have the age at initiation of hydroxyurea therapy in years. And what you can see is that, let's take the bottom right panel here. This is the set of patients, real or predicted by the model, who were enrolled into the registry at 40 years old, right? So they were enrolled into the registry at 40 years old. And you can see that the majority of them on average were put on hydroxyurea initiation at around 35 to 40 years old or so. And that seems to be the case regardless of when they are diagnosed. So each dot in this bottom right panel represents a different age at diagnosis. And you can see that age of diagnosis actually has little effect on when the patients were put on hydroxyurea. But you can see, looking across all 4 panels, that age at enrollment has a significant effect. So what does that mean? Next slide, please. So what we concluded from this is that the age at which patients are put onto hydroxyurea therapy correlates with the age at which they were enrolled in the registry, but not at the age at which they were diagnosed with sickle cell disease. To put it another way, patients are not put on hydroxyurea when they're diagnosed. They are put on hydroxyurea around the time they're enrolled in the registry. And this, to me, speaks of one of the key or the important aspects of a disease registry, that it helps to promote care in areas where it perhaps would not otherwise have been considered. Next slide, please. So we also asked how the age of diagnosis of sickle cell changed across the different enrollment sites within the consortium. And what we found was we first worked out some crude estimates of the median age of sickle cell diagnosis per country. And we found that on average, patients in Ghana are diagnosed at 3 months. Patients in Nigeria are diagnosed on average at 19 months. And patients in Tanzania are diagnosed on average at 3 years old. But what we realized is that the age at which a patient is diagnosed is also strongly correlated to the age at which a person enrolls into the registry. So for example, someone who enrolls at 40 years old is more likely to have been diagnosed later than someone who was enrolled at 5 years old. So we wanted to correct for that effect. So we built another regression model to help us separate out those 2 effects. Because also we noticed that the Nigerian cohorts were older in general. So patients recruiting into the registry from Nigeria tended to be older, typically, than those from Ghana. Next slide, please. So that's basically what I was saying there, that age at diagnosis correlates strongly with age at enrollment, and the Nigerian study populations were the oldest in the registry. So we built a regression model that helped us correct for these factors. Next slide, please. So here are the model predictions for the best fit regression model that we created. You can see in this plot, it's very similar to the last plot I showed. The numbers in the gray boxes above represent the age at enrollment of a patient. And now each dot represents a particular healthcare facility. So all the green dots there represent healthcare facilities in Nigeria. That red dot there corresponds to a healthcare facility in Ghana, and the blue dots correspond to healthcare facilities in Tanzania. And what you can see is that for patients who are enrolled in the registry at 5 years old, that's the top left box, on average, most of these patients were also diagnosed at a young age, younger than 5. But if we move to the final box, patients that were enrolled into the registry at 40 were on average diagnosed with sickle cell disease at very different ages, depending on the country at which they came from. So you can see that Tanzanian patients recruited into the registry at around 40 were diagnosed much later in life, around just before their age 20, than those in Nigeria or in Ghana. So what does this mean? Next slide, please. Next slide, please. Oh, cool. Yeah. So what this means is that after we adjust for the age at enrollment, we see on average that sickle cell patients in Ghana are diagnosed at the same age as sickle cell patients in Nigeria. This, of course, is assuming that they are not part of some national sickle cell screening program. And so we thought a bit about what this might imply. And we realized that in Nigeria and Ghana being countries that are quite close together, typically the same sickle cell haplotype is found in populations in that part of the world. Whereas in Tanzania, a slightly different sickle cell haplotype is the most common. And in fact, this translates into disease severity. So we estimated, and this speaks a lot to the theme of this session, that those who have a more severe form of the disease are more likely to be diagnosed earlier than those with a less severe form of the disease. And we realized with this model that this particular diagnostic, the age of diagnosis, can be a very useful marker for disease severity in sickle cell epidemiology research studies. There are several factors that are involved in that you have to make sure you correct for, such as economic development of the region and so on. But we found that we estimate that the average age of diagnosis of a sickle cell patient is, from an epidemiology point of view, a very good marker of the average disease severity in that region. And we found that this was not true for something like hydroxyurea use and uptake, because many factors come into play in influencing whether hydroxyurea use uptake is large or small, many of them being economical, so or resource driven. But we found that age of diagnosis seems to be a very good marker of severity. And I think that future research studies, particularly registry ones or epidemiology ones, can really harness this measure, this index, as a way to try to estimate how disease severity changes in different parts of the world. So next slide, please. Okay, thank you very much. That's the end of my talk. I realize I've gone a bit over, but I'd like to thank the organizers again for the opportunity to describe our work. And I'd like to thank everyone involved in the research of this project. It's far more than just me. But okay, thanks, Corona. Back to you.
Thank you, Dr. Jack Morris, for that. So what I'm going to do is allow people to type in their questions in the question and answer or in the chat. And we'll read the questions at the end of the session when we have a panel discussion. I just want to confirm if Prof. Kindo is now able to present. Can we put up his slides? Wilson? Are you able to put up the slides?
Dr. Patience, I'm sorry, I do not have access to Prof. in this slides. I was wondering if Dr. can share.
Okay, Prof. Kindo, maybe you can share your slides from your end. I think they've enabled you to share.
Okay, just a few minutes.
So maybe while we wait for the Malian team to sort out the slides, we can have Miss Togola. She's a mom of a sickle cell disease warrior who comes from Mali. And she's a member of the Sparkle Mali, which is led by Prof. Kindo, and also an advocate and member of the AMLD. And she's a teacher at a secondary school and training coordinator at a training center for heavy machinery. Miss Togola, if you could speak while we give Prof. Kindo time to sort out the slide projection issue. Thank you.
Good afternoon, everyone.
Good afternoon. You are loud and clear.
Okay, thank you very much for this opportunity to permit me to speak about sickle cell disease people from my country. Thank you very much. Okay, here we begin with the networking as the first part. The importance of networking. I would say that in my country, we understand that networking is one of the best way to help sickle cell disease people. It was the main reason for what our support group was created. And in our support group, we didn't just take sickle cell disease people. We understand that it is important to take the stakeholders with all those who are involved in the management of the sickle cell disease must be included. So we had to, in the network, we have to put together our experiences. As it was difficult for the parents to find the health workers who can really take care of their children. They thought that it was better to put patients, medicine, or doctors, or all those who work in healthcare and caregivers too. Not only the caregivers, we call them in French here parents, les drépanocytaires et parents. So speaking about parents is not just the father and the mothers, but all the relatives who can help in managing this illness was included. So parents with their children, 1, 2, 3, sometimes more children in the same family who has this SCD disease was very, very difficult to manage. And for a mother spending all the day with her baby, crying and not knowing what to do could be very difficult to support. So when we are together, I have a sickle cell child, you too, and other people, we can try to exchange to permit to each of us to see about what is time. It is not easy to speak really about the problem we bear inside ourselves with another people without the feeling of being judged. So when we are with someone who has the same problem, we feel free to speak about all. And the fact of being with other people also help us to understand that we are not alone, and permit to the patient and the relatives to understand that they don't need to make comparison with themselves and other people who don't have this illness. So they share the everyday realities and also share the different solutions they could find. Also, they making people together in a network permit to remain in touch in order to share opportunities or many other things. For example, here in Mali, when we are together and we are with other support group or other stakeholders, we can exchange the realities. I can ask them, they can speak about the opportunities they have at their level, and I can do the same too. It will become easier and faster. So as I told, when we speak about putting people together, it is not only the sickle cell disease people, but sickle cell disease people, caregivers, researchers, health workers, founders, and all those who want to take part in the same group for an effective and efficient struggle. Next slide, please. Speaking about the challenges faced by people with SCD and some possible solutions. So we have first the misunderstanding of SCD and its complication. People didn't know the illness and they can't understand that the sickle cell disease people can fall in crisis at any time. So seeing a child playing right now and in 2-3 minutes to see the same child crying and not knowing what to tell is very difficult for other people to understand. Sometimes it is even difficult for his own mother or father to understand. So this creates many problems with sickle cell disease in the society. It can lead to disputes in this family, the father, the mother, or other people, other relatives. It can lead to, it even leads to divorce in our society. The father and the mother who couldn't understand where this illness come from. So they will always be criticizing each other, which can lead to divorce. It also can lead to dismissal. So at workplace, when the boss can't understand why his employee is always absent, even if he doesn't have any problem, because in our big cities, we can have a follow-up. So for this, the different follow-up, we are absent. When we are in crisis, we are absent. And sometimes there are some work which can be urgent and you are not here to do it. So it can be a problem. And sometimes all this misunderstanding leads to suicide or make the people, the SCD people can have think to suicide, even if most of the time they didn't do it, but the family can understand that. Sometimes they even say to the family that they want to make an end to their life because they feel themselves like a burden for the society, for the family first. So when we speak about the complication, the treatment of sickle cell disease is a very, very financial problem in our societies for the average population. With even a SCD child, it is difficult. So we can think about having 2, 3, or 4 sickle cell children. And sometimes it is not only just our children. We can have some cousins, some nieces or nephews, some aunts who had the same illness like your child. So you feel yourself obliged to assist them financially. And that's make things very, very, very difficult. So we spoke about the psychosocial aspect and all the challenges that the sickle cell disease people face. Each of the challenges can be psychosocial aspect, psychologically, especially because being inactive, the inactivity of SCD people, when you don't work and you are the one who spend all the money of the family, that is a burden. Even if your parents, your brothers agree to do it for you, sometimes you will feel yourself as a problem of the family. We also have lack of care and lack of access to medicine. medicine that is in big cities, we can see inside our countries, we lack of care, we lack of diagnosis. Sometimes people will discover that their children have sickle cell disease after 10 years, 15 years of fighting. And most of the time we will find that they already have the complications. So the solution we propose here is to make our decision, our authorities, national authorities involved in the fight so that they can bring the care inside the countries, the diagnosis first, then the care. Because speaking about newborn screening, that's not a reality in our country, in Mali first. So the solution we propose here for the diagnosis is that the authorities make it their problem and they do everything to bring care and diagnosis medicine inside all the country to permit to each one to have a solution wherever he is in the country. We also have non-involvement, as I speak about non-involvement of authorities in the fight, lack of national SCD program. So national SCD program will permit to have all the aspects we have to face for the management of sickle cell disease. They will permit us to know how to communicate the information we can give to the population to permit to change their feeling toward the SCD peoples. We have school drops also. Our sickle cell disease child or children are sometimes obliged to stop studying because of they are most of the time at home, either in crisis or they're at the hospital for the follow-up. And we don't have a means to make them study at home or to make the school come back on what they have done when they were not present for their during their absence. So that make them stop studying very, very, very early. And knowing that SCD people can't do physical efforts, so when he can study, he become a man. He can't do any job which asks for physical effort. He become, I don't know how to say it in English. He will become a kind of burden for the family. Being a woman, when she will get married, perhaps when she has an husband who can help her. But being a man, it is very difficult because he's the one who must support the family. Next slide. Okay. Debate and discussion also is a big solution because that is also one of our main objectives, our main mission in our support group. We do many sensitizing sessions. It will permit to attract the attention of decision makers for their involvement in the fight against sickle cell disease. It also help get SCD out of shadow because it is true that we are speaking about SCD for a long time, but even now we know that in our societies, people don't know about the disease. They are still hiding SCD people's. The SCD people themselves try to hide themselves because they fear the judgment of the others. They don't want people to discover that they are not able to do such or such thing. And those who accept can avoid psychology problems but those who have problem to accept it are still trying to hide themselves, and the family too, the society also reject them. They will say that it is not directly, but they are rejected. So when we speak about this illness, we make much noise around it. It will really permit to get it out of shadow and to demystify SCD, because until now in our societies, people think that when you have this illness, it is because of bad persons, it is because of bad angels. So sometimes some family even refuse to find solution to go to the hospital because they think that it is not an illness which can be treated at the hospital. So speaking about it, making much noise around it will really help SCD people not to continue to hide themselves. Okay, thank you very much.
Thank you so much, Ms. Togola, for that wonderful description of how the patients with sickle cell disease walk in this journey full of challenges. So in the interest of time, I will move to our fourth speaker. We have Prof. Gindo speaking last. I'm sure by then the technical challenges will have been sorted. So we have Prof. Saf. Oh, are you ready, Professor Gindo?
Yes.
Okay, you can share your slides.
Can you see the slide?
Yes, please. You can go ahead. Thank you.
Okay, thank you, Dr. Kwana. And I will not start my talk without saying thank you to the organizer for giving me the opportunity to talk about the subject toward establishing incidence of malaria among sickle cell disease patients. So I think the allocated time is 5 minutes. I will do my best to respect that. So therefore my talk will concentrated in the key point of the subject. So malaria is a red blood cell parasitic infection responsible for more than 600,000 deaths globally, with most of these deaths happening in young children in sub-Saharan Africa, where sickle cell disease affects 1 to 25% of the population. That means that malaria and sickle cell disease both are a major health problem concern, and we need to find solutions on how sickle cell disease population can be protected against having severe malaria or dying from malaria. And despite this recognition, there is a lack of comprehensive epidemiological data on malaria in sickle cell disease patients in most malaria endemic countries, particularly in the context of sickle in Africa countries. So what is the rationale of this topic? We want to address this knowledge gap by studying and aimed to advance public health effort to improve the health outcome of individuals living with sickle cell disease in malaria endemic region. And therefore, we draw a study named Observational Study to assess the incidence of malaria among children living with sickle cell disease in sickle Africa countries population. The objective of the study is to describe the epidemiology of malaria in sickle cell disease patients across Sickle in Africa consortium countries. And we have 3 specific aims. First, we want to determine the incidence of clinical malaria episode in sickle cell disease patients over a 1-month period. Secondly, to determine the incidence of asymptomatic parasitemia. And thirdly, to determine the incidence of submicroscopic parasitemia. The study will be a multi-country 1-year observational study whereby sickle cell disease patients at the selected clinic or the study will be enrolled for and observed for 1 year. So the study will have a duration of 12 months. And during that 12 months, we will collect some information. And this information will be analyzed and determine the epidemiological of malaria in sickle cell disease population in Sickle in Africa consortium countries. So where the study will be conducted, this study will be conducted in Uganda, Tanzania, Nigeria, Mali, Ghana, Zimbabwe, and Zambia. And we will have the opportunity to study malaria epidemiology in diverse sickle cell disease phenotype, including SS, SC, or S-beta thalassemia. And each country will recruit 468 participants with a total number of 1,404 participants for the study. So before to thank you, I think the expected result will be to identify the risk factor of having malaria in sickle cell disease population, the type of malaria, meaning the severity of malaria, and the asymptomatic of malaria cases in sickle cell disease population. And this is the outcome we are looking for. And we hope that from the study, we will sort out with a very strong epidemiological information of malaria among sickle cell disease population in Sickle in Africa countries. Thank you for your listening.
Thank you very much, Professor Kindo, for that very short but clear talk on the malaria incidence study. And I will repeat myself to say all the people with questions, if you could type them in the chat or in the Q&A so that we can then have a discussion at the end. So now we are going to have our last speaker for the session. This is Professor Safo. Is Professor Safo on the call? I don't hear him acknowledging.
I have one question.
Okay, thank you. So let me introduce you, Prof. So Professor Safo is from Kumasi, Ghana. He's a researcher, clinician, and educator. He's also a neurologist with 2 doctoral degrees in epidemiology and molecular medicine. His research mainly focuses on stroke in the sub-Saharan African context. He's the SPACO Ghana site lead and also site lead investigator on the SIRENE study, which is focusing on understanding the incidence and prevalence determinants of risk modifiers of stroke occurrence among individuals with sickle cell disease in Ghana. So, Professor Paul, you can go ahead and present your talk. Thank you.
Dr. Kona?
Yes.
Prof. Safo is not joined yet. Is he joining?
Yeah, I'm calling him to join.
Okay, thank you.
And to just find out from Lawrence if he can't get Prof. Safo, if he's going to be able to do the presentation on behalf of Ghana.
So Prof. Safo is joining. He's joining the next minute. Yeah, he just dropped out, so he says he's reconnecting.
Oh, okay. All right. Because I thought I'd seen. All right, it's fine. So we'll just give him a few minutes. In the meantime, I think I'll just summarize what we have heard so far. I think it's very exciting what is happening in the Sickle in Africa Consortium. And we know what has happened in phase 1, that there are quite a number of delays in diagnosis of sickle cell disease in Africa, at least in the 3 countries that were presented by Dr. Jack Morris. And there are also delays in starting important interventions like hydroxyurea therapy. And then there's a disparity in utilization of hydroxyurea, with some countries having very high usage. And we know it's an intervention that really improves the quality of life. Yet countries like Nigeria had very low utilization of hydroxyurea, in spite of it being the first I think one of the few African countries that is actually manufacturing hydroxyurea. So the researchers in Africa have to address these disparities so that we can have all our patients accessing life-saving interventions and quality of life improving interventions. And then from Mali, we have heard from 2 speakers, a patient advocate who has highlighted the challenges that caregivers are facing. And the patient groups are trying as much as they can to offer each other psychosocial support, but there are still challenges in accessing diagnosis and standards of care for sickle cell disease. But there's more that can be done for sickle cell disease patients to improve quality of life and psychosocial outcomes, and to fight stigma. And I think she emphasized one of the solutions was to involve decision makers in the fight against sickle cell disease, decision makers in the family, in the home, in the community, and at national level, so that at least they can prioritize decision making, which will improve their lives and the psychosocial outcomes of the patients with sickle cell disease. And we've just heard Professor Gindo talking about the malaria incidence study, which is a very important study because we know patients with sickle cell disease do experience severe morbidity, and there's increased mortality when they get infected with malaria. And it is very important to understand the epidemiology of malaria so that we can then plan interventions that actually will save lives for patients with sickle cell disease. I hope Prof. Safo is now back on. Yes, I see him. Prof. Safo, you can go ahead and present.
Hello, good afternoon. Good morning, everyone. Thank you for this opportunity to be part of World Sickle Cell Day. I'm not able to, okay, right, good. Am I able to move the slides? Yes, please. So in this brief talk, I'll be just taking us through the SCD severity, sickle cell severity, by looking at the complications of sickle cell disease. We all know that sickle cell is really a multi-system disorder, and it's quite complex. And individuals living with sickle cell disease do experience acute as well as chronic complications. So this beautiful slide shows us the involvement of sickle cell disease in the various end organs. And in the slide, you can see that the yellow depicts acute complications such as meningitis, hepatopathy, gallstones, kidney issues, trapezium. And then the green depicts the chronic complications of sickle cell disease. Next slide. So we see here that individuals living with sickle cell disease tend to experience certain complications that is distributed across the lifespan. So for instance, some of the conditions over the period of time tend to increase in the frequency or prevalence in sickle cell population. So for pneumonia and acute chest syndrome, we note here that, for instance, when in the young, less than 6 years, you have about 30 to 40% prevalence. But as the age increases, you have it rising all the way to about 60% when they are more than 50 years. So the chance of experiencing some of these chronic complications tend to increase over time. But notably, you will see that for kidney disease, which is depicted in brown, there's a very steep increase in the prevalence of kidney disease around age 30 to 50 years. And when patients more than 50 years, the incidence increases sharply. So these are some of the complications that we tend to see in sickle cell disease. On this slide, I'm not showing, or you're not seeing, the burden of stroke in sickle cell disease, because in that particular study, they did not capture the burden of stroke. We want to share with you some data from Ghana. This is work I believe that Evans has published, looking at the burden of complications in sickle cell disease in Ghana. Next slide. Oh, where's the slide? Can I move it from here? Thank you. So here, we see here that the burden of sickle painful events, comparing the event rate per 10,000 person time, we compared those with SS genotype versus SC genotype. And we realized, for instance, that sickle painful events occurred about 141 per 10,000 person follow-up. Notably in the SC, we saw a higher incidence of acute painful events. And then severe anemia secondary to hyperhemolysis was more frequent in the SS than the SC. That is expected. Malaria, which Prof. Gindo we are going to look at, the incidence rate was about 17.46 per 10,000 person months, compared to 12 in the SC genotype. When it comes to stroke, and I'll talk more about stroke, purely out of interest because I'm a neurologist and my interest is in the neurological complications of sickle cell disease. We note here that for those who were the SS genotype expectedly, we saw close to 13 events per 10,000 person years, compared with 4 events per 10,000 in the SC genotype. Acute chest syndrome and avascular necrosis, as expected, avascular necrosis was commoner. The SC genotype tended to have more avascular necrosis than SS genotype. Next slide, please. Next slide. All right, so what accounts for this variability? What accounts for this variability in the phenotypes of sickle cell disease? Because as clinicians and those of us who are involved in patient care, we see that no two individuals living with sickle cell are the same. And sometimes this great variability, as scientists, we try to understand why this exists. Some of the variability we see in the phenotype of sickle cell disease has to do with geographic variabilities due to perhaps genetic variants that are prevalent in certain populations. But there are also epidemiological clusters where we think that what explains the phenotypic differences are usually due to common biomarker mechanisms. So we have about 4 subphenotypes that we encounter in clinical practice. You have a group of patients that have the vaso-occlusive subphenotype. This particular group, we tend to have a higher hematocrit, a higher viscosity, and therefore there's a predisposition or a predilection for vaso-occlusive pain crisis, acute chest syndrome, and osteonecrosis. And then we also have a group of a particular cluster of patients who have hemolysis and vasculopathy subphenotypes, where they have a lower hematocrit, but they have hyperhemolysis. So LDH levels are high, bilirubin levels are high. And those particular group of patients tend to have a predisposition to ischemic stroke, pulmonary hypertension, leg ulceration, gallstone trapezium, and then nephropathy. And then we also have a subgroup that have a high hemoglobin F subphenotype, where they have a persistence of expression of hemoglobin F, sometimes 10 to about 25% of their total hemoglobin is hemoglobin F. And interestingly, these genetic variants tend to be associated with decreased clinical severity. And that's believed one of the ways why hydroxyurea promotes a lower clinical severity. And then we have those that have pain subphenotypes, i.e. some individuals who have sickle cell disease are more pain sensitive, others have pain protective phenotypes. And that is believed to be due to alterations in the neurophysiology of pain transmission pathways. So all these variability in presentations are quite interesting, and a lot of work is currently going on to identify what explains some of these different subphenotypes so that we can discover and uncover new treatments that can push one individual from one phenotype to a better phenotype. Next slide. Next. Yes, so I'll focus on stroke in the next few minutes and we'll be done. Sickle cell anemia, of course, as we know, is the most common cause of stroke in children. And stroke is one of the most devastating complications of sickle cell disease. In fact, when you compare with their peers, children with sickle cell disease have over a 220-fold increased risk of stroke and over a 410-fold increased risk of cerebral infarction. Now, 10% of patients with sickle cell anemia will have clinically apparent stroke by age 20 without any prophylaxis. And by age 45, about 24% would have suffered a stroke. Next slide. So what is the burden of stroke among patients or individuals living with sickle cell disease? This meta-analysis involved about 30 studies conducted in Africa, and the pooled prevalence of stroke in sickle cell disease was 4.2% overall. Next slide. If we're to break this pooled prevalence per country, by far, Nigeria has done the highest number of work on stroke, and the average prevalence is between 1 to 12% of populations. The highest population of strokes tend to be in the Kano North area. When you come to, for instance, Cameroon, studies have shown that the prevalence of stroke is about 7%. DRC is about 1%. Uganda, 6%. Kenya, 7%. Tanzania, 8%. So this shows that the burden of stroke overall is quite high in most of our patients that we are taking care of. Next slide. We're interested also in doing a contemporary evaluation of the burden of stroke. Most of these studies that were done before the gradual introduction of hydroxyurea into routine care. And so in Ghana, we've introduced hydroxyurea into routine care. So we did a contemporary evaluation of the burden of stroke. And what we found from interviewing or assessing over 4,000 individuals living with sickle cell, we found that about 0.9% of them had a stroke, which is lower than the pooled prevalence of stroke across Africa. Now, we don't know whether this is largely due to the introduction of hydroxyurea into routine care, but we are doing prospective follow-ups to see if this can be replicated, or we can see this a drop in the incidence as we follow participants over time. Next slide. So for the pathophysiology considerations, usually the overt strokes that we see in sickle cell disease are largely due to large artery vasculopathy, and it tends to affect the very big vessels in the brain, the intracranial portions of the internal carotid arteries and the middle cerebral arteries. It is also notable that up to about 50% of individuals by age 50 would have silent strokes within the territories of the penetrating arteries. And I'll show you later on that these silent strokes are not benign. Next slide. So the cause of stroke in sickle cell disease is quite heterogeneous. In the children age group, we find that cerebral infarction predominates. But as the vasculopathy or the changes in the vessels in the brain progresses over time, there's therefore an increased risk of having intracerebral hemorrhage. And the most common subtype of overt cerebral infarction is the borderline stroke or the border zone stroke, which occurs between sometimes the anterior cerebral artery and then the middle cerebral arteries. Next slide, please. Next slide. So what are the ways in which stroke presents or cerebrovascular diseases present in sickle cell disease? One, we have the commonest type is the acute ischemic stroke. And here we want to teach our patients so that, and their relatives, so that they can recognize the symptoms of stroke as soon as it occurs, because interventions for managing stroke are best administered as soon as the symptoms occur and not wait till the symptoms become fully established before you present to clinic. So for acute stroke, patients may present with sudden onset of weakness on one side of the body. They may present with loss of sensation on one side of the body. Sometimes it may involve sudden loss of vision or visual cuts. Sometimes the walk, the gait, the way they walk might change, which we call ataxia. Sometimes you want to speak, but the words doesn't want to come. Or sometimes you are talking, but it doesn't seem to make sense, which is called dysphasia. And occasionally, when the stroke is so big, you can have loss of consciousness for an ischemic stroke. Sometimes too, the stroke may be due to the fact that there's a bleed into the brain, and that may present with severe headache, a new onset seizure, or loss of consciousness, and that may occur with or without hemiparesis. Occasionally, we may see patients come to us with acute subarachnoid hemorrhage with headache and neck stiffness. And then central venous sinus thrombosis is also very common in patients with sickle cell than the general population. They may come with headaches, seizures, and sometimes focal neurological deficits. And then there's this syndrome in sickle cell, which is commoner in sickle cell, I should say, posterior reversible encephalopathy syndrome, where the patient may just come with altered mental states, headache, and then changes in the vision. And sometimes if you're not thinking about it, you may actually miss it. Silent infarcts are quite common and they are not benign. We are currently planning to do some studies to evaluate the predictors of silent infarcts using MRI. It is known that those with silent infarcts, for instance, when it occurs in the cortex of the brain, tend to predispose individuals to having seizures. So sometimes the seizures we see are because there have been infarcts in the cortex. And these infarcts are silent because they've occurred but didn't manifest with symptoms, and they are sitting there quietly. Over a period of time, there are changes in the structure of the brain with gliosis and the rest, and that becomes an epileptogenic focus that can cause seizures in individuals living with sickle cell. These silent infarcts too can disrupt brain networks and affect cognitive performance and cause cognitive decline. So that performance in school, for instance, may decline as a result of these silent infarcts. So these silent infarcts are not benign. Next slide. So when a patient has an acute stroke, what should we do? In Africa, a lot of individuals, when they have a stroke, symptoms of stroke, are not aware that they're having symptoms of stroke. So they may say, well, let me a bit, that is often not a good decision. As soon as you have neurologic deficits, you must present quickly to the hospital so that you can be assessed quickly. Usually we need to do a head scan, either a CT or an MRI, to find out the type of stroke. You know, we said that the stroke can be an ischemic stroke, it can be a hemorrhagic stroke, it can be a subarachnoid, sometimes it can be a venous infarction. And without doing the head imaging, it's sometimes very difficult to know what type of stroke it is. And without knowing the type of stroke, it is sometimes difficult to know what type of specific treatment to give to the patient. So presenting to hospital very early is very important. And we have to also be able to get a CT or an MRI done as soon as possible. You know, in individuals who have had a stroke, in the general population, when somebody has an ischemic stroke, always say, oh, take aspirin, take clopidogrel. But that is not the approach, or at least the acute approach that we have for patients with sickle cell. The goal when they come with an acute stroke, at least standard of care, is to do rapid exchange transfusion. However, in Africa, we know we are challenged and we can't do rapid exchange transfusion. So sometimes what we do is that we just give them simple transfusion and want to aim to increase the hemoglobin concentration to about 10 to 11 grams. Now, when a patient has an acute stroke, for instance, in general practice, we say acute stroke, acute ischemic stroke, presenting within 4.5 hours, give thrombolysis. But in sickle cell disease, this is quite controversial. And the role of tissue plasminogen activator for management of acute stroke is still not highly recommended. Next slide. So because we have limited resources, because we have limited resources to be able to manage our acute strokes, for us in Africa, I think our focus should be on primary prevention. Primary prevention, primary prevention. Primary prevention of stroke refers to identifying patients who haven't had a prior stroke, but are high risk of developing a stroke so that we can intervene before they develop stroke. Stroke is a very, very severe phenotype, complication of SCD that causes morbidity and mortality. Now, so how do we screen to identify individuals at high risk of developing a stroke? We know that transcranial Doppler ultrasound ideally is what we should do. And in some centers in Africa, there are transcranial Doppler services available. When this is available, we should do it in children who are usually between 2 to 16 years so that we can identify those with abnormal blood flow to intervene. Next slide. So what a transcranial Doppler does really is just to measure how blood is flowing through the big arteries in the brain. And so usually if we realize that the velocity of blood flow is very fast, what that means is that the intima, the diameter of the blood vessel has become a bit narrow. And that is why the blood flow or the velocity has increased. And that's when we pick it up, it's a marker that this person is at higher risk of developing a stroke. So usually when we measure the velocities, we may interpret it as normal, conditional, or abnormal. So what is a normal, or what's the abnormal cutoff? Abnormal cutoff is when your timed average mean maximum velocity is more than 200 centimeters per second. When you have more than 200 centimeters per second, you have a 40% increased risk of stroke within 3 years. And so, and those with 170 to 199 are deemed to have conditional abnormalities, and they are monitored closely. Next slide. Next slide. Yes. So when you read the literature from the West, they will say once your TCD values are above 200, start with transfusion, chronic transfusion. And that was based on the STOP1 trial, which showed a dramatic benefit. But look, the truth is that we can't do these chronic transfusions in Africa. So for us, we have to look at how we can use hydroxyurea and use it more effectively. So that's the Twitch study, for instance, which was also done elsewhere in the US, also show that yes, after you've been able to do this chronic transfusion for about a year, and you've been able to stay zero, which is good news for us. But for us in Africa, still we don't do this chronic transfusion. So that is why the spring study was so timely for us in Africa, because spring Nigeria be able to prevent strokes. Enough group would have been a no hydroxyurea versus hydroxyurea, but it's not ethical to also withhold treatment. So what they ended up doing was to do a low dose hydroxyurea therapy of 10 mg per kilogram per day with a moderate dose hydroxyurea therapy, 20 milligram per kilogram. And what they realized was that low dose or moderate dose was associated with a comparable stroke incident rate. However, those on a moderate dose had a lower rate of hospitalization compared to those with a low dose. So for us in Africa, I think hydroxyurea implements something that can reduce the risk of stroke based on the TCD readings. Next slide. Next slide. Next slide. Thank you. Now, what do you do for a patient who has already developed a stroke? We want to prevent further strokes, and that's what we call secondary prevention. And for us as neurologists, that is when we come in, to be honest. We come in after somebody has had a stroke and they're asking us, so what next? So we do secondary prophylaxis. Unfortunately, hydroxyurea alone cannot be used for secondary prevention, at least according to the data from the SWITCH trial. The SWITCH trial is a stroke with transfusions changing to hydroxyurea, which was a controlled randomized trial where they used hydroxyurea versus chronic transfusion for secondary prevention. And what they found was that there was a 10% prevalence of stroke in the hydroxyurea group compared to 0% in the transfused group. So they said based on this that, well, then hydroxyurea alone may not work. But then again, I always say that you must contextualize clinical trial findings. So this is clinical, okay? It's available. That chronic transfusion is not available. So even though it was able to reduce it, or the prevalence of stroke was 10%, it is better than the 50% prevalence without any prophylaxis. I hope you get my argument. Without prophylaxis of any sort, the risk of recurrent stroke after having a first stroke is about 50%. With hydroxyurea, they found a prevalence of 10%. Okay, so I would argue that, yes, so we get trials that are done in Africa comparing different doses of hydroxyurea. And I think there's a trial ongoing comparing doses of hydroxyurea for secondary prevention. I would err on the side of using hydroxyurea till I find evidence that it doesn't help my patients. Next slide. Next slide, please. So on the horizon too, there are interventions that we are developing for specifically for stroke prevention. There's hematopoietic stem cell transplantation that is yet to come on board. Interestingly, there's also voxelotor. And voxelotor is an agent that stabilizes hemoglobin S in oxygenated states, and it prevents polymerization and erythrocyte sickling. So they've done trials on this. The HOPE trial really didn't measure or look out for, because the HOPE trial mainly looked for acute chest syndrome and vaso-occlusive pain crisis to establish its efficacy. So they did not look specifically for stroke, but it is gratifying to note that when they used the vosiletor group did not report any stroke, which is also very encouraging. And then there's also the prizanilizumab, which then regulates the endothelial expression of P-selectin, thereby reducing inflammation-mediated cell adhesion. Here again, the SUSTAIN trial also showed decreased VO crisis and acute chest syndrome. And these are interventions that are in the horizon that may be useful for preventing stroke and most of the chronic complications of sickle cell disease. Next slide. Next slide. So in terms of future directions, what can we do? In Africa, I think that's what we need. There's a lot of studies that have reported on the prevalence of stroke, but longitudinal cohorts that are able to report on the incidence of stroke, especially now that we have hydroxyurea gradually taking roots in Africa. It would be great to establish cohorts that look at incidence of stroke across large groups. And I believe that the Sickle in Africa consortium offers us that opportunity to be able to do this. Number two, I think that a questionnaire-based stroke screening instruments where clinicians can routinely use a set of questions to find out whether the person has symptoms of stroke or not, or symptoms of transient ischemic attack or not, is worth developing for wider use in Africa, given that in Africa, we don't have a lot of our patients are seen at the primary or the grassroots levels. So we need to be able to build capacity at that level for people to be able to at least pick up symptoms of stroke as soon as possible. We also need to evaluate the impact of sickle cell disease on neurocognitive performance, and then build our national capacity to conduct clinical trials on primary and secondary prevention of stroke and other complications of stroke. Next slide. Next slide. So I'd like to conclude with this slide by looking at how we can prevent these common SCD complications. I always believe that everybody believes that actually, that prevention is better than cure. So preventive strategies have really changed the long-term outcome for sickle cell disease more than any other approach. Prevention of life-threatening infections with penicillin and prevention of stroke with hydroxyurea has drastically reduced childhood mortality in sickle cell. So generalized screening of individuals with sickle cell for risk factors and early aggressive disease modification should be implemented to reduce morbidity and mortality, whilst looking for specific screening for pulmonary, renal, and systemic hypertension, retinopathy, and damage to other end organs should be implemented so that we can improve the quality of life and outcome for individuals living with sickle cell. So with this, next slide. Next slide, please. So with this, I'd like to thank you all very much for your attention. And I've really enjoyed this day with you. Thank you.
Thank you so much, Professor Safo, for that wonderful presentation and for taking us through sickle cell disease morbidity and severity of this morbidity, but particularly focusing on stroke, which seems to be 1 to 12% incidence across the few African countries that have looked at the epidemiology of stroke, meaning that there's a lot of gaps in information that we need to actually focus on this important complication of, which is a very quality of life limiting. And that probably we should be focusing on primary prevention because of our challenges in Africa to access the standard of care for management of stroke using TCD and hydroxyurea. Thank you so much. So we will quickly discuss. I'll go into the chat and just look at the comments there. If there are any comments for any of the 4 speakers. So we had a comment from Prof. Chilolo. I'm not sure if he's still on the call, where he was saying that we need to give more attention on the risk of suicide, sad and tremendous reality, which is increasing in sub-Saharan Africa. Really psychoaffective support is needed in the management of sickle cell disease. I think this was a comment towards what the patient, Miss Togola was talking about, the sickle cell disease warrior. And we have a comment from Olani, who quite agrees with Prof. Chilolo, especially when one considers the poor socioeconomic status of some of the sufferers of the disease. And from Ms. Togola, do you want to say something? Because I think you then commented in the chats. I don't know if she's still on the call.
Yeah, I'm here.
You can go ahead and comment.
Okay, I would just say that sickle cell disease people, I don't know if there is a possibility to help them to become also financially independent. For those who stop with the studies very early, to help them find something they can do for themselves in order to be able to take part in the family's expenses. That too can also help them and also help the family to see that there are not people who can't do nothing, who can do nothing. Yeah. Thank you to all of you. Thank you for the opportunity.
Okay, thank you so much. So we see there's a lot that we can do to support our patients so that we can mitigate the mental health effects, the impact of sickle cell disease. And Dr. Nchankwi also commented and agreeing with Prof. Chilolo's comments that there's a lot of psychosocial impact on the health of patients with sickle cell disease, and that there's a need for data on psychosocial issues to inform evidence and best case. So it's very important that the researchers take note of this, because I think the patients keep bringing it up in all the consortium meetings that we have had, and it's quite something that we should address.
So Vic, just to jump in terms of psychosocial data on psychosocial issue, I think one of the data that we are collecting data on anxiety and then depression, I believe, in our adolescents and then our adults in our cohorts. So we'll look at the data and see what we can learn from it. But it appears to me, a cursory look at the data suggests that, like you're saying, there's a high burden of comorbid depression, perhaps higher than your average population, in the order of 50 to 60% of participants reporting scoring high scores on the Hamilton Depression scale. But we had to analyze the data fully, so we may be contributing some data to answer the question. Over.
Thank you so much, Prof. Sapo, for that. And then there's been quite a number of requests. I'm sure people from the CCC and the DCC are seeing the requests to how can people contribute. I think it was to the malaria study and also to the registries. I see a comment from Riyum Salam from North Africa. They're wondering how they can contribute. I hope someone can speak to that. And then there was also from Francois, who would like to be involved in Anastasia. So I will leave that to
if I can weigh in.
Yes.
What I think what has happened is that for people to be part of a registry, really, we shouldn't make it difficult for them to do that, because mainly it is about demographic characteristics and clinical events. And so we could share our templates with countries or institutions that are willing to contribute data to our joint registry, so that although we agree that data is coming from Mali, Ghana, Nigeria, Tanzania, Uganda, Zambia, and then Zimbabwe, I'm sure that the contribution from North Africa will help us have the global picture of sickle cell in Africa. And I believe that Sickle in Africa offers that opportunity to do this. So maybe at the CC or DCC level, this could be considered so that we make it possible for others to contribute so that we can learn from the data available in other countries. Over.
Thank you. And I think previously in the previous session, Vicky did post in the chat the website for the Sickle in Africa for people, because the sickle cell disease ontology is open for everyone. I think what may be a bit of a challenge is the funding for the studies. But I'll let somebody from DCC and CCC speak on that. And then there was a question from Michael. I think it keeps coming. It was from my previous session where there is asking from the epidemiological perspectives, what are the best laboratory technologies for the early screening and detection of sickle cell disease in the resource-limited countries? And he really would like an answer because it keeps coming even in this session. So anyone who would like to take that before I could say something? Professor Gindo? Is he still online? Would you like to help to answer that one?
Can you repeat which one, which question?
So this is a question from Michael Akonaye. I hope I'm saying that correct. From the epidemiological perspectives, what are the best laboratory technologies for the early screening and detection of sickle cell disease in the resource-limited countries?
Wow, great question. So in terms of screening for sickle cell disease in limited resource country, it depends on many factors. But I will talk about Mali experience. In Mali, initially we were using IEF, which is less expensive but more accurate. Since we got HPLC, we moved to HPLC to screen, but I know that HPLC is not accessible for everybody because the expenses of the reagent. But the most way I think to struggle with that concern is using RTD, which is not sufficient because RTD alone is not enough to be able to diagnose sickle cell disease for some of the phenotype. But in Mali, we never study only hemoglobin. We associate CBC to hemoglobin study to be able to diagnose. For example, if I use an RTD and I found a AS with, for example, anemia, with microcytosis, and with some biological parameters excluding iron deficiency, then we can say that it's not an AS. But this is too much combination information. I think the most easier in Africa today to be able to diagnose properly sickle cell disease is the EIF, which is the less expensive, but the less expensive but accurate technique to diagnose sickle cell disease in a limited resource country. That's my part.
Okay, thank you, Prof. Ginto. I hope, Michael, you've been answered, but there's a lot of information available on the point of care tests and all these newer technologies that are coming that we think, as long as it doesn't need a lot of electricity, too much expertise, and a big laboratory to offer the test, that will be the correct test. We must learn from all the other things that we've done in Africa, particularly from the communicable diseases where we know point of care tests work and they will move and increase access to diagnosis in the community. So On that note, I think I would like to thank everyone who participated today in the first day of the webinar series, and to just thank you for helping us to commemorate World Sickle Cell Disease Day. And then I would like to keep in our minds today, there are a number of sickle cell disease warriors who are actually hospitalized, not feeling well. We must remember Miss Molly Chima, our sickle cell disease warrior from Zimbabwe, was also not feeling well and failed to present because she fell sick. And then to just thank our sickle cell disease warriors and advocates for walking this journey with the clinicians and researchers and policymakers who tend to speak in very complicated language, but they continue to hang around us, reminding us of the essential components of the contextual sickle cell disease care package for Africa, particularly for us to always remember the psychosocial impact and mental health effects, besides the other things that we are pushing for to improve the quality of life of the patients. And thank you, everyone, for joining today. I think I will give the mic to DCC for us to close.
Thank you very much, Dr. Patience, and to the speakers and to all the participants for joining today. So tomorrow we are meeting at the same time. I'll just project the schedule for tomorrow, if that's okay, and we'll circulate that around again so that everyone is up to date. Basically, we've got very interesting sessions tomorrow. We've got We've got very interesting sessions tomorrow. We've got 2 sessions, one from 12 to 1:30, where we've got a policymaker from Uganda. We've got Kofi Ann from London, Ghana, and Professor Obi also talking about newborn screening, and Arafa, a patient advocate from Tanzania. And later on, we've got improving access to established and emerging treatments for SCD in the afternoon, late afternoon from 1:30. So we only have 2 sessions tomorrow. So we look forward to seeing everyone back tomorrow and continuing with our discussions and deliberations. Thank you.
Thank you, and good evening or good morning, whatever time zone you are in.
Thank you.